Good morning, everybody, and welcome. 6th of March, we are the University Hospital Liverpool Group Board of Directors. Welcome with a number of colleagues who will be joining us. Apologies for today's meeting on basic non-executive director Tracy Ellery, non-executive director David Gilbert will be arriving part way through the meeting. I've just had a message from Sarah Walker, who's delayed getting here, but will be here shortly. Also, we're missing today David Melia, the person here in Bolin. Jan Ledwood is away, and Chris is here. Chris, welcome. And also apologies finally from Siobhan, who's on maternity leave. I'm very pleased for our meeting today to welcome new non-executive Sue Gray. Welcome, Sue. As colleagues will know, we've been through a recruitment process to fill some of the gaps in the non-executive director team, and we looked in view of the direction of travel that we're moving in with the group and the increasingly collaborative working with the specialist organisations in the city. We looked this time particularly if there were members of other boards who were interested in joining the group. Now, Sue is also the senior independent editor at the Walton Centre. Trust them will continue in that role as well as joining our board. So it's really great to have you here, Sue.
Okay.
We start today patient story. And Jim, we're joined by Dr. Nikhil Mishra. Nikhil, please come forward to the table. Jim, do you want to say?
Thank you very much, Chair. I get this good job quite often now, don't I? It's a privilege today to introduce Mr. Nikhil Mishra. Nikhil is a trauma and emergency general surgeon, worked with Aintree for considerable time. I'm not quite sure how long, Nikhil, but amongst many of the superstar things that Nikhil is involved with, one is setting up essentially this program called Knife Savers. And if we think about the kind of political context coming from the centre after the Darcy review about a shift of, if you like, secondary care to community care, about prevention, better cure, and so on. I think if we put that in this context and you hear Nikhil's story, to me, it's inspirational in many ways, but it helps us think about how we, as a trust, as essentially an acute hospital trust, can think about how we upstream on care. This is a great example. So if I may, I'll hand over to you.
Good morning, Jim. Thank you so much. That was a very, very, very kind presentation and an introduction. It's a real privilege to be asked to come and to present to the board today. Thank you. My name's Nikhil Mishra. I'm a consultant general and trauma surgeon. I have been in Aintree for a long time. From Liverpool originally, trained away for many years, came back to a situation from down south back to Liverpool where I hadn't met before, which is an increasing number of emergency cases coming into our hospitals due to victims of youth violence and knife crime. Down where I trained, Bristol and Cambridge, we didn't have this. So when I came back as a senior registrar, I met trauma cases that were clinically stimulating and intellectually stimulating, but tragedies, things that shouldn't really happen. I'm going to talk you through the story of Knife Savers. Just to put into context, Knife Savers is now a national campaign, recognition in Westminster, and I'll come to that in a bit. But we're very proud that it's based here. It started here in Liverpool, in Aintree, and parts of University Hospital groups of Liverpool. Basically, this is something we're very, very proud of, and it's going to be a big year for us. So we've seen these headlines over the last few years. These are true. The highest rate of knife crime over 2 years ago. 18 months ago, 2 years ago, sorry, the fatal stabbings in England and Wales have reached the highest level since records began. And these are terrifying statistics, as it were. And this is our lived experience as clinicians here in the trauma centre, but actually anywhere, in any hospital. And any of you that are parents or or have young children in the family or teenagers. This is frightening. We think about this as well as being doctors, clinicians, healthcare personnel as well. These are ONS graphs showing the rates of incidents of offences of knife crime per 100,000. The top left one was from 15 years ago. The bottom right one was from a few years ago. The darker the colour, the greater the rate of offences. So actually, in the top left, it was the worst places for knife crime offences, East Midlands and London. Bottom right, it's a band extending from where we are across the north of England, and actually large areas of East Anglia and East Midlands. Things have got worse nationally. And this is the context to which we're delivering our healthcare. And the headlines came through thick and fast about horrible incidents of young people whose lives are taken away, most of the time by a single stab wound after an escalated argument, after an altercation. It either started at social media in school, but culminated with a single fatal wound. This is a young lad called Daniel Jameson. He lost his life here at Aintree around 6 years ago after a single stab wound to his groin. I was the trauma surgeon on duty that day. I couldn't save him. Our team couldn't save him. I took that picture to remind me forever of the scene that I saw as we tried for hours to save his life. And this was after a culmination of a really, really bad summer of a number of incidents that occurred like this. It's really difficult to then switch back to clinician mode and be a doctor again. And I went home and I had a real cathartic moment. I thought, I need to make this better. And there's a few colleagues here in Aintree who said the same. We can't carry on like this. This is breaking us. So I had a long think. I wanted to start some sort of public access education campaign and came up with the idea of Knife Savers, hugely supported by the Trust in terms of an innovation grant and help on how to evolve this. We came together, and it's interesting what you said about collaborative. This is a truly collaborative campaign. We worked with people all over the city, all over the hospitals, different hospitals, all over grades. This is not a doctor thing. This is a healthcare thing, of not just clinicians, but management staff as well. And actually, embedded into this is the idea that we are an anchor organisation to actually reach out with just delivering healthcare, but to actually make the city a better place, the region a better place, and actually eventually the country a better place as well. The idea of Knife Savers is just this, to educate and empower literally anyone and everyone how to control bleeding. And I'm just going to take that last bit out from knife wounds. It's actually from any cause. Any cause of major injury, we educate the general public on the very simple steps on how to control bleeding, what blood loss is, how quickly you have to act, and also fundraise and deliver vital trauma kits, which I'll come to in a bit, around the region. So two parts to it, education and kit. The education bit, why bleeding is so time critical, why you have to act quickly, and also very, very much more pertinent for the schools and the colleges we go to. I went to talk several thousand young people over the last 6 years. This year's a big year for us in terms of education, is the dangers of a single knife wound. I truly believe that is not really known amongst our young people, that the act of a single knife wound, a stab, and this is from the evidence, the data that we get, is not regarded as an act of violence. Now that both terrifies me and gives me hope, because it means that we can work on that. And also the kit, bleeding control packs and cabinets. These are the kits that I designed around 6 or 7 years ago, worked with a company called Prometheus at the time. 3 bits to it. Top left is gauze that is put inside the wound. It packs the wound. It's got procoagulant on it, makes blood clot quicker, 3 times quicker. Secondly, the bandage, an elasticated bandage that goes around the wounds to add the compression to the packing within the actual wound. And finally, a tourniquet. Now, a tourniquet we don't normally use in knife wounds, but I kept them in there when we were designing these, just in case there was a mass casualty incident, like a blast incident, not thinking that that would actually ever occur in Liverpool. And then the incident occurred at the Women's Hospital, where an attempted casualty event. So that's why we kept those in there. And cabinets, I designed these cabinets after the mortality, the death of a young girl called Ava White in the city centre. We had thousands, this is a young girl, Christmas lights were being put on, she escalated argument, a single injury to her neck, which unfortunately she succumbs to. She bled out. Now, we didn't have any of these kits publicly accessible. And what I wanted to do is to get almost like defib cabinets, but around the region. Now, these didn't exist. I mean, there was an incredible amount of friction to changing a city centre by putting big red cabinets up there, but we did. And there's now dozens around the city centre. Every school in Sefton, if you go to the Sefton area, has one of these outside now. Every school in Merseyside, we've worked with a charity called Cash for Kids, they have a bleeding control pack. So to almost saturate our area, not just with the kit, but with the knowledge on how to use it as well. Don't forget, this is based from here. Started in 2019, where we started our first big event. We trained up around 40 to 45 bars and clubs from around the Seal Street or Parr Street area from the city centre. Massive event, hundreds of people coming through, and we taught them with our clinical team like a conveyor belt of bleeding control education, really successful. I then had the idea of how do we get, those were static bleeding control points, what about mobile ones? So I thought, you know what, I'm going to go and approach the taxi companies. And they bit my hand off, they thought it was a great idea. So we got all the people that had their patch around the city centre, and we trained them as well. And we trained them up in a similar event. Oh my word, just less than 100 came in. We trained them up in one day, 2 sessions. There's a number of them now that go around in the city centre with our packs in, who've been trained up by us as well. Just before the pandemic hit, we started moving out into schools, and one of our first schools that we went to was Riverside College in Halton. We trained them up, their teachers and their staff. Around 2 weeks later, 2 of their students were in a fight and were injured with knives. They were bleeding out, the helimed were called in, they came to us. They survived. Why did they survive? Because the teachers were in knife savers mode. This made us very proud. The packs were used and the education was used. And actually, this is the very first evidence of the real effect of the campaign of what we did. Moving on to part 2. We work very strongly for our next move. We wanted to actually get to the demographic, into the heads of certain people. And we've used the vehicle of sport. We work really closely with both football clubs, Everton and Liverpool. We've done loads of work with Liverpool and twinned with the foundation. We're doing some work with those with the foundation again in a few weeks' time. Using the power of the badge, the communication from the Premier League. And we run, again, big events where hundreds of young people come in from local schools, and we train them and we get the opportunity to talk to them. Now, I love these events. These are probably the highlight of my year, because we have the opportunity to talk to young people one-on-one. They never get the opportunity to talk to trauma doctors. People who, this is our lived experience. And they come and they talk to us, and they ask us questions about, hey, when was the last time you saw this? And we said, well, you know what? I was on duty 3 days ago. I was dealing with a patient who was injured. And they look at you, and then you know you've got them. You've got the opportunity to get into their heads. They listen to you. Whether they contain or retain that information is time will tell, as it were. But you can tell the engagement from these sessions is absolutely huge. Bottom right-hand corner is Emily Spurrell, who's the Police and Crime Commissioner. We've done a number of sessions with her. She's a huge fan of knife savers and the Liverpool Hospital groups as well, and does a lot of work with us. Well, we're very, very grateful for them. We have the opportunity to ask questions. Thousands of young people, we have asked, why do people carry knives? What would make them stop? We're working with, and we've created a research and knowledge exchange group with the Public Health Institute at John Moores University, Professor Zara Quigg, to collate this data and intelligently analyse it, to hopefully give us the largest youth voice as to youth violence in this region in the country. And that's what's overwhelmingly come out. Why do people carry knives? Protection. We're going to work on this. Every Merseyrail station in the region has one of our packs, and we've trained them up. Every school in Merseyside either has or will have a bleeding control pack and access to our education, which we've moved online. We continue to go there and give the education in person. And every school in Sefton has one of these boxes outside if you're driving around the sort of Formby, Crosby, Southport area. It's one of our big red boxes outside there. We've made a very strong link with Liverpool John Moores University, and as I said, we've created a research and knowledge partnership. And we're part of the group where we train them up. Around 1,000 nurses and paramedics have been trained up. It's part of their curriculum now, where they undergo knife education training to cascade that training themselves. We've been fortunate to be on the news a number of times to cascade our message out as well, flying the Liverpool hospitals. I was on the red sofa a couple of times as well. Again, just giving our view of what we're doing in Liverpool, how we're making this better. And because of that, we were invited up to Westminster a couple of years ago. Very, very proud. Went up there, spoke to the all-parliamentary group on knife crime, again, representing the city, representing the healthcare, to tell them about what we're doing to make this better in Liverpool. We can't be everywhere, so what we're doing, have done, and are doing this year is actually we've moved all our training online. We've written, after a large fund, an e-learning program which will be accessible to all schools. It's just being tested at the moment. Testing we'll get the results through from the testing in the next 2 weeks, and this will be accessible to every school for free. So this will be not only our how to stop bleeding, why is it so quick to act, but we then follow that up with a visit from ourselves as well. Put them in the diary, and one of our team will go over to facilitate an education session in the PHSE sessions in schools. But also this, we've actually written, and Jim's had a look at this as well. I'm bring one in to show. Is actually a virtual reality package on knife crime, the effects of knife crime, why you stop bleeding, all the stuff we talked about, but actually in an immersive environment. So that will be added on to the PHSE sessions. All of this is done. It's all filmed. It's all been paid for. We've been getting charitable grants and working really hard over the last 2 years. So we're going to go live this year. We've got the ability to actually be to reach thousands and thousands of young people in the region. And after that, we will go back to Parliament, and we'll be on parliamentary group, knock on their door, say, look, we've got something to show you. What we've done in Liverpool. Look how we've got into the curriculum of all the schools. Look about how we're getting into the heads of all the young people, telling them about the danger of a single knife wound, how to stop bleeding. And look at this data we've collected. Look at probably the biggest body of evidence as to why young people are carrying knives and what will make them stop. But actually, what it all boils down to is a collaborative effort. We've got people from all walks of life all over the city. There are literally thousands of people that have signed up to this since I started this 6 years ago. And it's a truly collaborative effort from schools, police force, the Police and Crime Commissioner, all the hospitals and all walks of life as well. As I said, don't forget, start it here. Thank you.
Thank you, Nikhil. Great story, great presentation. Comments, thoughts, questions, please.
Thank you. That's a really powerful presentation, Nikhil. And anyone with children, fear that kind of that environment that we're growing up in, and they're growing up in nowadays. Any education is really important. Do you link in with sort of the ex-convict rehabilitation? I can't even say it. Rehabilitation. Because there's probably nothing more powerful than some credibility in terms of people that have been in that environment, maybe been victims or even caused knife crime or injury, that can also tell a story and really educate.
Yeah, I think that's a really, really good point. So one of my other hats is I'm the health lead for Merseyside Violence Reduction Partnership, working with Merseyside Police. So via that avenue, we have got people that we want to contribute to this. Already as part of the e-learning package that's already out there is the narrative of the best friend of a young man who was stabbed, who went out carrying a knife and got caught, and he did time. And his narrative is incredibly powerful. We want to get more narratives in there that will speak to young people will make them think twice, as it were. The virtual reality package, the headsets that follow the e-learning package, also have a narrative from young persons that spent some time, and also inside a custody suite. We filmed inside a custody suite. So you can imagine putting a VR headset on and looking around at the custody. It's incredible. I'm a total convert to virtual reality education now, I have to say. But there's also more space and more room for that. We're getting feedback from the young people that we're actually showing this to, because, as a bit of an old man, I think I know what works. But we've used a lot of young people's voices to help us write the material. And we will always go back and say, well, actually, does this work? What works? What doesn't work and has been proven is scaring them. And in years gone by, there used to be people going to school with knives, pictures of wounds and stoma bags and catheters. Those days have gone. They scare and cause more harm than good. And that's evidence-based as well. But actually, there's a role for what you just said, which is actually getting the lived experience of someone they relate to who's done time or has actually, done time, been punished for carrying a knife or injuring someone.
And I wonder just on that, whether there's an opportunity for big technology firms like Microsoft and Sony who, provide gaming services, a lot of these young, they're people who get involved in knife crime, often spend an awful lot of time playing computer games, probably detached. So there's another sort of route there, isn't there?
100%. Yeah, no, definitely 100%. Definitely.
Have an expert.
Thank you, Nikhil. Really, really a great story, but it's very passionate, and it's nice to hear your passion for it. I'm interested in you as a jobbing consultant, and the post-incident trauma you must experience in your colleagues. And do you do anything specific to support colleagues that face it? And thinking about recent incidents in our city. How do you help your colleagues with that?
I mean, that's a really, really good question. We're talking about now in the trauma group. We don't have anything. We don't have anything. We do it ourselves with hot and cold briefs. There's something called trim training, which is what they use in the military, which is almost a debrief, psychologically based framework. Don't have access to psychology as yet. Our patients do, but you're absolutely right. I was the lead surgeon for the Southport incidents. I also worked with Merseyside Police as well. I saw the forensic debrief of the Southport incidents. It's horrifying. There's a dad. It's terrifying, basically. This was a doctor as well, basically. So nothing formal, but there is scope for that to it's not just me as well. There's a massive trauma team out there, who've dealt with all these incidents over the years as well. You're absolutely right. There's a bit of a vacuum where that needs to be filled.
For more.
Thanks. I'll come. So I've got Peter next, please.
Yeah, amazing, Nick. Great presentation. Great stuff. Really, is going on. Representing Liverpool is really, really important. Actually, leading the way.
Thank you.
Scourge of our society, really, isn't it? I'm just interested in whether or not we're seeing improvement in some of the headline data. You said you've got lots of data. Are we beginning to see? Are we beginning to make an inflection into the curve of rates of knife crime, deaths, severity of injuries, and anything like that?
Yeah, absolutely, really good question. So we are. And with Merseyside BRP, we have a massive data warehouse and regular reports come out as well. So we've created a violence prevention regional group, which I'll definitely link yourself or anyone else into.
Yeah.
On a regular basis, reports will be coming in to show that. So small changes. But 18 months ago, there's fantastic headlines that we've had the highest decrease in knife offences, the second highest decrease in the country. That was 2 years ago. And that flattened down a little bit, basically. And that was because of lots of work from the VRP, healthcare, a number of initiatives around. That's flattened off, unfortunately. The figures have been skewed by Southport, what happened in terms of mortalities and the injuries, as it were. And we're kind of hoping it goes back to a better level. The feeling from the front line is it's better. It's not gone. It definitely hasn't gone away. And I think one of the worries about the media reports is it's very binary. It's either shocking and the world's about to end, or everything's brilliant. Basically, and it's never the real story, which is it's in the middle somewhere. Yeah.
Thank you, Nick.
Sarah, then Rob, then Beth.
Thank you, Chair, and apologies for coming in part way through, but even the bit that I heard is just phenomenal. So thank you for the passion that you've got and for using it. My interest is for something that I do outside of this. And you said you've gone to Westminster. How much are government looking at this fantastic work that you're doing and looking at that to become a blueprint? Because I'm part of a similar discussion in Manchester at the moment. I'm the chair of an academy, and we lost a pupil to knife crime earlier this academic year, which was just harrowing. But it's really, really difficult to get different communities together to anchor around that. So what you've done is brilliant. How do we maybe with my other hat kind of support more on how Westminster takes some of that and starts to drive that more universally?
Yeah, so two very good points. So healthcare, we have a really unique advantage, and people listen to us. Our lived experiences dealing with patients who've been injured. We're not there in police uniforms or wagging our fingers, which automatically the young people are switching off to. We're there in jeans and a hoodie most of the time, even like an old fella like me. Basically, they're listening to us, and this is why they took us on the shoulder, on the elbow, and they come and have a listen. Have you dealt with this? and then they listen to you. So from that raw material, we have this unique opportunity and unique advantage to speak to them, and leveraging that is what's made this so powerful as well. Westminster is hugely political. Idris Elba, and all the different groups that are coming out there, that they're going to make this better. The conversations about punishments basically it all muddies the water. But where we stand from coming from a healthcare perspective, and the uniqueness of it is our advantage. So how do you go back to the idea is to, from our idea, is to collate the data of what we're going to do this year with the e-learning and the virtual reality helmets, hopefully get a big enough body of evidence to say, look, we've taught over 2,000-3,000 young people. This is the feedback we've got from them. This is the feedback from their schools. We'll never prove it has a direct effect on knife crime rates, but I'm hoping, my vision, by the time I retire, is going to be that it's instilled into the DNA of the curriculum of the country, basically. Knife injury awareness and DNA, and it started here. I'm so proud of. Did I answer your question?
It has. I might connect separately on a few things on that, but thank you very much.
Thank you, and Rob next.
Brilliant.
Thanks, Nicola. Brilliant presentation. I was around at the time, innovation grant actually, and I remember it was brilliant then. And just seeing what you've done is stunning. We set aside some money for innovations, and that's exactly the kind of thing that we want to do. My question is around, obviously, again, as a parent, scares you to death, doesn't it? We've got over 17,500 people who work for this organisation. Is there a route that, as parents, as education, we can get, or as employees, that to help the message and to help the cause?
Yeah, I think that's an absolutely fantastic point. Yes, is the short answer. I want to leverage the fact that one of the biggest employers in the region, basically. Small steps. I mean, I could do with some help and how to escalate and to accept. We have a message to give. Can land in lots of people's heads and can make them have a conversation with their young people themselves, as it were. And we've seen that in the schools we've worked with. We've seen that in other non-education environments, the police, the fire service, that people are coming up to us going, you know what, I listened to you. I've gone back and asked my lads, what are you doing? Do you carry a knife? To stimulate those conversations are better than a vacuum of nothing happening, basically. I think it'd be brilliant. I would love some help with leveraging that. We have the content to disseminate, whether that's virtual or in reality. I would twin that with the work that we're doing with the VRP, the Violence Reduction Partnership, the Home Office funded police initiative. They've got a lot of data, a lot of information to get out there. And as the health lead, one of the things I'm tasked to do this year is to bring that message about violence prevention and reduction to University Hospitals of Liverpool, so the 18,000 odd people that work here, basically, because I think that can make a difference, I have to say.
Thank you, Chair. Hi, Nicole. Hi, how are you doing? So I've seen this journey, and you know my view on what you do. And we've been really supportive to you. But for me, and it's a bit what Sarah was saying, but just going on that little bit further, what I've seen you grow this is your personal motivation, energy, enthusiasm, and you've made this important to people. It's not just all the material and everything else. You have spoken at boards. We've got people really on board. So I suppose my question is this. We need to scale up this as a national problem. You started the presentation with that. And even if Westminster and the blueprint is set, where this could fall down is finding similar-minded people with that drive to make this important to them. And so I think that's going to be a little bit of a stumbling block, but I don't know whether you've had any thoughts of how you create that team. And so you create that groundswell, you know, across the country. And I think that kind of speaks across to what Sarah was saying.
Yeah, 100%. So, yeah, no, absolutely right there. No, thank you so much. There's really kind words. I've known you all the time. I've been here as a junior registrar to an old man. So no, thank you. So that's what I thought. Are we going to do this? Other groups that do this pay their volunteers, basically. I've always had a fundamental issue with that. Naive, maybe. We've got a group of over 1,000 volunteers now that do this in their spare time, like me, regularly. So at least once a month, there's a group of us that do 2 or 3 sessions in our days off, basically, because we know we're making a difference and it's great fun. And I thought, you know what, exactly as you thought, are there any other crazy people that would do that, but our group is massive. So the senior team is four clinicians now who basically run this in our spare time. We've got an immediate clinical training team of over around 120, 130 people from all hospitals, Wiston, Alder Hey, the Royal here. So this is the truly collaborative nature of it, as it were. And an actual junior training team, as I said, it's been installed into the curriculum of John Moore's nursing and paramedics of thousands. So, and again, we do it in our spare time. I don't think it's unique to Merseyside or Liverpool that we want to make a difference. And having spoken to colleagues around the country, I presented this to the Royal College of Surgeons, they love the idea. So I know there's people that want to do something similar in different parts around the country. My model, which may be wrong, is to prove our effect. To actually, because it's a crowded area, knife crime. We want to solve knife crime. I mean, look at Idris Elba and all the stuff that he's done, basically. You know, makes it very emotive and then disappears. We haven't disappeared. So how do we then go back? And the way that we wanted to do it is all of this innovation that we've done, I hope it makes a difference, but to somehow prove it makes a difference. You know, even if we stop today, we've got one of the 5 boroughs of Merseyside has bleeding control cabinets outside their schools. All teachers trained up. So already we know we have the potential to make a difference, as it were. So rolling this one back, there is enough people, as been proven over the last 4 or 5 years, who actually want to do this. And at some point, the goodwill may go, I have to say, but it hasn't so far.
Not the good way.
Thank you.
Thank you. Jim, anything you want to say about the conclusion?
Well, I'll be quick, Chair. I mean, thanks, Nicole, as ever. I love the connection to us as an anchor institution. What do we do as an organisation for our own workforce and for the populations we serve, all our staff whose kids and the links to John Moore's University, I think, is very important, which I'm intending to try and help with. And I have had the pleasure of using the VR headset. Made me slightly queasy when I was in that cell, to be honest with you, but it's really impressive and fun. And I reckon we'll see if we can.
Okay.
Thank you, Chair.
Thank you. Thank you very much.
Thank you.
Nicole, that's great. And I can guarantee you that things that you've said will be in the minds of people after this meeting, when we're all going on to our next thing today. So it's a huge impact. I also thought your positive comment, slightly deferential to the Chief Finance Officer, was very tactically astute. Thank you very much indeed for coming along.
Thank you so much for the opportunity. I really appreciate it. So much appreciated.
Thank you. Thanks.
Obviously, send to me.
Yes.
I just think like
You're welcome.
Okay, we have the minutes of our meeting on the 30th of January in front of you for consideration and approval. Any points anyone wishes to raise, either accuracy or question? Everything okay? Can we approve those minutes then, please? Thank you very much indeed. Move on to the rolling action tracker. Daniel, can you just remind me about this one? I couldn't remember the context. We talked about the executive director group feeding into non-executive director.
Yeah, so at the last meeting, James and the chief exec's update talked about a range of action executives have been tasked to deliver following the CQC well-led inspection, and we agreed that the list of those issues would be circulated to Ned. So
it's that specific issue.
Yes, Ned's had sight of the actions, and we'll be, once they're sort of updated, we'll be bringing an update back and sharing that with non-exec directors.
Just to reiterate, that was the, as we've said at the last meeting, rather than wait for the reports, these were the things we felt were the things that, you know, we needed to get on top of as quickly as possible. The reports may come back and have different things in them, but they were the sort of the list that we thought were the right thing.
Okay, thank you.
They're all been reviewed, by the way, and are on track, but the final list will come.
Thank you. I've not been notified of any urgent matters arising, so we've got straight into the Chief Executive Officer.
Thank you, Chair. So a few things to note today. Planning guidance. We've got a conversation later on in the private session just where the latest position is. But as we all know, we're expecting a very challenging year in terms of in terms of financial plans. Again, we'll cover some of that later on today. Planning guidance, we saw, I think, in summary, a much reduced list of targets, which was very much appreciated. And what was really pleasing was to see that improving safety in maternity and neonatal services was the key headline around quality. In fact, it was the only one. So it was great to see that, because that's something that I think most of us would feel has been, very much missing for a few years now in that planning sense. How that translates, we don't know. Rob will fill us in later on some of the finances, but you can certainly see an improvement in tariff for some maternity services, which is great. And we can see some improvements in tariff around some of the urgent care side as well. So again, we remain to see whether that's given with the left hand and taken away with the right in some of the way, but we'll see. Delighted to report, and I think all of you know anyway, but I'm saying it again, that the Liverpool Women's Hospital has now been granted university status, which is fantastic. So Liverpool Women's Hospital is now a university hospital officially. So congratulations to the organisation, well deserved, and just goes to show that their significant involvement in research and education has paid off. And I think that's brilliant for another one of the hospitals within the group. We have confirmation that we'd approved the maternity incentive scheme, and that was countersigned by the ICB. That had obviously been through the board. As everybody knows, significant focus on that, challenge on that. And as we discussed last time, really good progress that we were able to get to the position we have. That's been approved now by the ICB, so all of that is done, and we should be getting published guidance for year 7 in April. There's some news in there around LQA, which is great, because we've got a couple of platinum awards, which I was reporting on the trust brief yesterday. Grove Street car park, bit of an operational issue, but this was a slight concern to us because of how quickly it came about. So this was announced was it a week before last, wasn't it? And Jenny and I had a call with the council chief executive, I think the Friday, but it was being announced basically. So we only had a few days' notice of this. Obviously, that's council-owned land, and this, for those that don't know, this is the car park over the road from the Women's Hospital, which is used for both staff, but also we know patients use that car park as well, and it's quite significant in size. It is council land; it's owned by the council, so it isn't ours. But the proposal to build on that a new school, which I know has got lots of community opposition around other elements, particularly the Caribbean Centre relocation. So it's come as a bit of a left field. The conversation with the council was very much, look, the women's needs the car parking space. We need it for patients, we need it for staff. So you're going to have to help us come up with another solution. To which obviously the response was that they were happy to try and do that. So Jenny's leading on that with the council chief exec, just to see what we can come up with. We've identified other land around the hospital that might be suitable, ownership, who owns it, how you get hold of it, to be discussed. So again, Jenny will be trying to resolve that one. We think that it is likely that we would lose that by the end of the year. So I think the latest, isn't it, sort of. And again, that depends on everything progressing as planned with this school development. So slight left field one, bit of an issue, but we're looking at a possible solution that would be just as close by. Obviously, in terms of partnership updates, it's now been announced that I'll be taking on the role of Chief Executive at Liverpool Heart and Chest from April. Obviously, it's now been announced that you previously discussed here that you will be the chair as well, Chair, obviously.
Yeah.
As you know, you welcomed Sue at the beginning, and again, opportunity to welcome Sue. Really delighted that we've been able to make additional non-executive director appointments that, again, help us with the partnership work. Sue's obviously on the board at Walton as well, so it makes great sense that we've now got Ned's, as we did with Women's and Luft originally, who've got more than one hat and more than one understanding of what's going on across the system. So that's great. And the LASP has been developing as plans. We've got the assurance report later on, which we're going to cover today. So I think they were the key things I wanted to pick out in terms of news. In terms of the performance update, some of the things that were concerning in the month that we were just looking at was the sickness absence rate, particularly, is for the last 2 months has gone outside of the statistical norm, which is unusual. We knew last month when we talked about that in the winter period, there was quite a significant amount of flu and so on in the December period. But actually, on review of this last week, I was away, but colleagues reviewed it. Doesn't look like it's that. It looks to be more associated with stress, anxiety, other issues. So, matter of concern, still looking at that. Whether or not there's a link with obviously the challenges and pressures on the system, vacancy controls, other things is something we're just exploring. But it's certainly outside of control limits for 2 months is unusual. So we're looking at that, particularly high at Broad Green, which we'd noted previously, less so in some of the other strands. Overall, we think that needs further look. So we're doing that and we'll report back on that next time. The A&E side of things, because that's always a pressure for us, has actually been performing reasonably well comparatively. If you look at it nationally, 40th out of 123. As I reported on the team brief yesterday internally to the trust, the really pleasing thing is that our triage times are in the A&Es at Royal Aintree are still well over the target at nearly 90% against that 85. That was always a concern, as people know, of the CQC in years previous. You know, are we actually categorising and seeing people in order, making sure we understand the risk? And I think we clearly are. And again, the treatment times have been high as well. So I suppose the matter there is that they're not where we'd want them to be, but comparatively, the organisation is performing well, but more to do. In terms of the women's, I'm going to come to Jenny because when we come to Jenny's report later on, because the Never events reporting, which was on a rolling period, people will remember we wanted to move away from rolling as a metric, but Jenny's going to pick that up later, and we've had some questions from the public on a couple of these metrics, so I'll just let Jenny do that in her report, if that's okay, so we keep it all together. And then again, the only other bit of the women's, and again, I'm sure Jan will cover it, but is we're starting to see some real statistical improvement around past diagnosis for cancer now, which is a big challenge for the organisation, as we know, on the gynae pathway, which is getting better and better. So really pleased to see that. So I suppose, Chair, where we are is, I'm going to come on to the risks on 65 weeks in the next paper. Coming to the end of the year with a bit of a challenge on 65 weeks, as we knew, but in an area that we knew it would be a problem, which is EMT, particularly. The urgent care metrics doing better than perhaps we thought they would be. At both the women's and at Luft in terms of gynae ED there, and then the 2 EDs in Luft. Cancer and the diagnosis, faster diagnosis standard all improving, but sickness a bit of a concern. So we just need to keep a close eye on that and see if we can get some further detail and try and correlate to areas of pressure to perhaps where we've got some of these vacancy controls, and just assure ourselves that it's not a result of people having stress and anxiety at being under pressure at work, basically. So that's probably the key headlines, but happy to take any questions on that, and I don't know if you want to do the IPR separately or as part of that report. We can come separately.
Okay, we'll do that. I'll take any points, questions, thoughts, please, on James. On this car park, can the council not just build as another floor on top of the car park that's on the site?
Well, there's 2 issues there. So the council own that land, obviously. The rent is very minimal, about 40k a year. So it's almost a bit of a, you can use this thing that's over there. It's been a fairly loose agreement over time. There is an agreement in place, but it's not I would say it could be easily challenged. So they have the right to take it back. So in a way, I don't think the council see this necessarily as their problem. They've allowed us to use a piece of land that was theirs for a period of time for a minimal rent. Now, that said, they were very concerned about the fact that if it was going to create a patient parking problem, that they needed to try and help us find a solution. When you look at the women's site, Jenny and Andrew Lewis and myself were all sat on Google Maps on the same call, looking at it from above on the pictures. It's quite constrained in terms of the parking sort of sits around the periphery on the sort of the green land that then is onto the main road. Makes it quite difficult to put multi-storey type arrangements in place. What we are trying to do is look at the area that sits behind the director's offices, the board area there. There's a sort of square car park behind there. There is land adjacent to that across the inside of the fence that is vacant. That's the bit we're trying to figure out. But it used to belong to the council at a point in time. Whether it still does or doesn't, I don't know. But that would very much allow us, if we could get the council to try and help us to basically just move extend that car park out and get everybody onto the site, which is actually better than people crossing the road. So it would be great if we could do that, but that's very early stages, and so Jenny's exploring that.
I just think the ripple effect of these type of things is we tend to underestimate in terms of people getting in on time.
Well, 100%, and absolutely, and well, as we know, the Caribbean Centre over the road is a huge asset to the community. That's now a major point of contention as well. So whether this will happen quickly or not, we don't know. But the main thing is making sure we get a solution, because the women's is not going to be quieter, is it? It's only getting busier. So we just need to make sure we've got that solved as soon as we can.
Other points, question? Okay. In terms of anything else you wanted to highlight from the IPR, or should we just move in?
Well, I do the group wide risks and the IPR as one item.
Yeah.
And then because I'll draw out the group wide risks. So in this paper, and I'm going to come to a couple of colleagues on this one. So the key, these are the corporate risks, obviously, that don't come out of the sites or the hospitals. These come through our senior management board, where all the hospitals are together. We've got a risk escalation around safeguarding, corporate nursing safeguarding about mental health. I'm just going to bring Colin on that one in a moment. On the 65-week elective time, the risk escalated from 11 to 12 back in July. Because of particularly ENT. ENT is under Aintree Hospital, and the sort of ENT head and neck capacity has always been a major problem, not just here, but nationally. And Peter's put a number of additional clinics in place, but during the course of the month, there's challenges around some of that. So Pete's going to pick up the 65-week risk in his reporting because it's relevant to his 18 weeks stuff. The follow-up appointments is still 412. We discussed this at length last time. And validation is still a big challenge. However, we did have a good discussion last board about the risk in there is deemed to be very, very minimal. We've not had any significant risk issues raised at all, but we still want to continue to keep that on track and deliver it. The CIP programme for 24-25 is still on there, but largely because we're in the last few weeks of that right now. Rob will give us an update later about how close we're going to get there. So we can pick that up a bit later on. And the same around the financial balance, which, as you know, the forecast was we're going to be about sort of 15, 16 million away from the control total position. There's some slight improvements in that. And again, Rob will take us through that later on. So I think the corporate risks are all covered on the agenda, with the exception of this mental health. So I was just going to ask Colin to update on that one.
Actually, so a decision was taken to increase the risk associated with patients presenting with mental health problems in hospital under the Mental Health Act, given an elevated risk across both the Royal and Aintree site in relation to increased number of incidents, response, and also some difficulties in trust staff managing some of the challenging behaviours exhibited by patients coming through. We have agreed to open up a mental health oversight group, and that's being introduced to help develop some mental health strategies and a training needs analysis for the organisation. And we're also looking to, at this point in time, it's in the next 2 weeks, engage with Merseycare colleagues in order to develop a plan and a programme of work to undertake some review of the operational pressures, understand how we can remove some of that risk and agree priorities going forward. So it is in hand in conjunction with Merseycare, but we felt it important to just elevate the risk at this point in time, given the pressures that are coming through from some of the sites.
So people may remember that we had a similar risk raised about a year ago, and it was where we felt we weren't getting the right level of inputs. And again, very similarly, it came from two acute receiving hospitals and the corporate teams at the same time saying this isn't quite where we want it to be. Numerous meetings with Merseycare at that point got us to a better place, recruitment, input, support. I think the key difference this time is almost, as Paul just said, trying to equip our staff better with some support and training and development as well about how they manage our side of that particular issue. So pleased to see that that's been a result of the risk being raised. So I think we'll look for a further report on that next month. The risk will still remain at 12 until we've had those initial discussions with Merseycare.
Mike.
Thank you. Thanks, James. I think there's an assurance loop to close on no criteria to resign. I think
The corporate risk rate is saying basically it's a stubborn position, still at 390. And I think in the finance report later on, it said it is the reason to reach the financial plan. I think we probably need a report here to say all the things that have been done, and a lot has been done, the impacts, ongoing challenges. But I think having gone through the CQC and the NHS thing around how do we get assurance, I think we need a more detailed narrative over all the actions and saying what the impact's intended to be and what the impact is. That's fine. I think good point. Where we're at the moment is in this sort of crunch period of, whilst numbers, it depends which way you look at it, and I'm sure this will come out in the entry and the roll reports. Whilst numbers might be the same, we're actually seeing quite significant improvements in the bits that we've got some control on. We're not seeing the improvements we want on the pathway and one-side patients, which is to do with the transfer care hub. We're at a critical point now with Merseycare, who are in agreement that it's not working, that particular part, and perhaps there needs to be a change in how that's managed. So what I would suggest then is if we bring back to the next board, it'd be quite a useful closure of this year. Here's everything we did, here's where it got to, here's what worked, here's what didn't. And then a bit of a look ahead to what are we going to do next year. What we've been clear on for next year is that we're not going to be taking on the financial risk of major CIPs on hundreds of bed closures, given the lack of ability of the system to support it this year. So if we do that as a sort of close down of 24, 25, where we got to, what worked, what didn't, and then a look at the year ahead, that might be quite great. Yeah, thank you. That's really helpful.
Question for Colin, please, for the Chair. The safeguarding issue, can I ask, is it predominantly in the emergency department? And does it increase at the weekend if there's lack of cover from Merseycare? Is that the real issue? And are there any issues around place of safety being used or abused by police taking people and there's no else to take them? Is that kind of, I'm coming from a position of a chair of a safeguarding board, so that's where I come from.
So just to the latter part of your question, the support and the police impact in terms of right patient, right place is sort of just allowing us to have more focus in terms of how we manage patients coming through from that arm. However, I would suggest that it's predominantly EDs where we're seeing the increased pressure associated probably with some delays in terms of the flow of patients through presenting with a mental health need. Hence why, in terms of the conjunction with Merseycare, looking to see how we can strengthen pathways for those patients coming through. And I think the other issue is that we are having experience of some challenging behaviour with our own staff in terms of being on the front line and experiencing some of that violence and aggression. And ultimately, where Merseycare can help in terms of some of that will be behaviours of concern management, and also making sure that staff are appropriately prepped and trained in order to deal with those types of situations. So that's what we're looking for from Merseycare and that collaboration.
But it's not unique, because I remember when I was at NWL, did a shift in A&E, and on a Monday morning there was like a cage, really, where people who had severe mental health problems were being detained. There's nowhere to send them.
Yeah.
And clearly the hospital isn't the right place. So what's ultimately the problem is the lack of secure mental health beds. But I'm happy to have a conversation offline. I've worked in Cheshire as well with similar issues around these issues. I'm happy to have a conversation with you to share my experience.
That'd be great. And unfortunately, often patients who are placed in ED, it's deemed as a place of safety.
Exactly.
And ultimately, it's trying to get around that and sort of looking to see that that isn't necessarily the best place for our patients, and ultimately looking for the next.
Happy with my experience where that helps.
Thank you, Jeffrey. Natalie, then Peter.
Yeah, just on that, Jeffrey, from a royal perspective, I think probably referring to the 136 facility, which are placed, that isn't the significant issue for us. So I met the ED consultant last week. For us, there's two elements. So there's the ED, which is more around, we have a mental health hub in, this is different between the Royal and Aintree. The Royal have a mental health hub. Our utilisation of that hub was not as good as it could be. And the SOP for long staying patients in there and the provision for them when they are in there for a long time was not what we probably would want to provide to our patients that come in with physical health needs. So that's the improvement plan we're working on with Merseycare. Lindsay, the site director of nursing, had a really good meeting with them last week. We've already seen a massive increase in utilisation of the hub following that meeting last week. And our matrons, for example, are sharing an office now with the Merseycare mental health matron, so that we get ED and mental health teams working closer together. The bit that has changed, which is why the risk, I think, is increased, is the wards. So we've got the ED as a consistent issue and pressure. But on the wards, we are seeing an increased number of patients that are staying in our beds for a longer period of time, and it's all due to the lack of mental health bed capacity.
So last week, for example, at the Royal, there are 7 additional HCAs being booked on every shift to one-to-one these patients because of their behaviours, and the staff are really struggling to manage these patients. So we've been having discussions with Merseycare directors on that in the last week, but I think that's where the training needs come in, because as well as the impact on the patients, it's our ward teams are really struggling and don't necessarily have the appropriate training in how to manage these patients. Some of them are with us for up to, at the minute, they've been there 3 weeks and they are medically fit and ready for an onward transfer. So I think that's where the escalation is. And I think, as Colin says, that's why we need to focus on training while we continue the discussions with Merseycare on how we improve flow.
I just asked too about on the ward, because I've seen that at Worcester, of young people who have severe mental health problems, are basically securely detained in an ordinary ward, and the resources that took were enormous, and we had it raised in Parliament, and we couldn't find beds anywhere in England or Wales, where it was not the right place for the patients, not good for the patients, and not good for the staff. And this is an issue that's going to be elevated further as well.
And that's where we are there.
But happy to share my experience before.
Thanks, Jeffrey. Thanks, Natalie. Peter.
Yeah, so that's really picked it up. I mean, it's similar for entry. So in the ED, it's a consistent. It's probably not as bad an entry as it will, but it's ongoing placement, not assessment, and then it's the impact of waiting for placement. But similarly on the wards, there is a placement issue. The entry very similar to the Royal. That's covered there. And the issue is not being able to find a bed. We talk about no criteria to reside in physical health. I think it's worse in mental health, actually. I think it actually is, look at the numbers versus people in waiting, it is actually statistically worse. So that is the key issue. So that's why we keep it well.
Thank you. Can I ask about the overdue outpatient follow-up again? What we sort of say the same things pretty much each board meeting. I know we're making some progress with this, but what has to happen for us to de-escalate this level of? So the risk we articulate, the risk of being there's potential harm happening to people due to the delay in coming back, and they sort of get lost in the system. But on the other hand, we're working through more and more this through the validation. How do we de-escalate this risk?
So at the moment, we've got 2 elements, haven't we? We've got the harm issue, which we discussed last time, and so that's not a huge risk for us now. What we've been looking at in the last couple of weeks, and actually, Heart and Chest, you noticed this on their IP the other day. So I've been looking at some of these other organisations that basically said, look, to have an eradication of something that's that scale is unlikely, particularly when the NHS planning guidance is to buy less. So what is deemed an acceptable number? And so I noticed, for example, at Heart and Chest, they've deemed a 25% threshold of people overdue their follow-up is reasonable, but once it gets beyond 25, it's not reasonable. And I'd like us to get to a sort of consistent approach on that across the organisations that we're working with, because we don't have that same discussion at the women's yet. So the women's haven't got this item squarely in the IPR. It's been raised a lot since you say Heart and Chest have got it in there, but with a threshold. So I think we just need probably a 3-way conversation between organisations about if we can assure ourselves on the risk to the patients is adequately managed, and then it becomes about ultimately effectively capacity and demand problem. And you can sort of agree a threshold that we deem to be reasonable and work to it. Whereas at the moment, it's a binary position. Either there are a lot of follow-ups or there aren't. I think that means it's going to sit there forever. So if you're happy to give us another month to look at that, I'd like to come back with a proposal about what would be a reasonable position. That's fine.
So I asked about that. When I was at Heart and Chest, the issue around outpatient appointments was never with us. One of the issues was the reluctance to discharge patients. It was like this sort of California hotel. We checked in, never went out. We were doing a session in the outpatient. Well,
I'll bet I'm mine for April.
Doing a session in the outpatient unit one day and talking to patients, and they've been good there 2 and 3 years, and they liked coming. Often from North Wales, and they liked going back for that reassurance. But actually, when I spoke to the clinicians, it was kind of safety, risk averse really about having a discharge. So that put an increased pressure on seeing people who actually needed to be seen, I thought. I don't know if that's still going on or not, but
I'm sure it will be. But we'll come back to it in strategy. See, we've got a clear strategy for the next year about what's going to make the difference on that capacity demand problem. Because the reality is, that this is, I think, the West Streeting point over and over. The NHS could continue to eat its budget 10 times over unless we address this problem of there's too many people coming to the wrong bits of the system and being forever kept there. And if we look at our care models planned for next year with the strategy, the work around diagnosis treatment pathway, we think, would radically reduce the numbers coming through the ED, but also coming in inappropriately into RTT practice and sitting there. The work that we want to do around some of the integrated care, integrated community partnership would likely reduce the referral onward as well, particularly now there's a payment mechanism for GPs to refer for advice rather than refer into employment. So all of these things coming together, we should be able to start to, as we get through the first quarter of next year, model what the impact might be. And I think what you'll see is a shrinking of the overall waiting list as a result. We know that a lot of the waiting list or follow-up appointments comes from people coming to ED inappropriately. Inappropriately in the sense that there were better ways to treat them, but for the patient, not a lot of option. Come through ED, stay overnight, be booked in for a diagnostic test, get a result, and referred to a specialist clinic, and then they're in that system. We think we can prevent that whole pathway with the diagnosis treatment work. So I think we need to, through the Strategy and Partnerships Committee, really get into what's the expected reductions, what's the expected impacts of some of these pathways if we put them in place. Because at the moment, we've still got a situation where GPs have got an A&E or an LCT pathway, nothing else. Yet we all sort of say, gee, please keep referring, there's too many people, there's too many come to ED, there isn't a lot of a choice. So that's the bit we really need to crack this year.
Thank you. Can I ask about the A&E performance? It's really impressive how quickly the A&Es have recovered from the critical incident. And the figures on ambulance waiting times and on family and friends are just fantastic. Has something fundamentally changed, or is this just recovery from a shock? Has the critical incident triggered something that's changed how we manage patients, how we manage pathways, or is this just returning to business as usual?
It may be, again, for you, Chair, but it may be that in the two updates, we can talk through what both sides, because there have been some significant, that sort of the week of the CQC, there were some fairly major changes made at Aintree around ambulance handling and so on, and there's been, again, more of the world. So perhaps if the two reports, we can pick it up there, and if there's any other questions, Tom, I'd probably just be repeating what you. Yes.
We're going, and just on that, deal with it in the way that you say, James, with Natalie and Peter. With on that, okay, we're 25 days away from the end of the financial business year now, and in our next couple of meetings, as the data becomes validated, we'll look back more reflectively on progress that's been made in this year. But I think this is one big high-profile, under pressure issue where we feel significantly better now than we did previously. And in our discussions in the autumn, was a nervousness, I think, around the table with everybody about what this winter was going to bring and how we were going to deal with it and so on. And I think that the progress that's been made and the way in which the past few months have been managed gives us great encouragement for the future. Everybody involved in this done remarkably well. But like you suddenly think, hang on, what was the magic bullet that got us from where we were to where we are?
Exactly, but back to Mike's point, we are seeing a significant reduction in that pathway 3Q, and that has a massive effect because we were pushing so many people down the care home routes and then spending 4 weeks in bed trying to agree a care home plan and all. And as those numbers are coming down, you only need, a small improvement in that space to take out a 4-week wait. So that it's back to that thing of total numbers might be similar, but the bed day impact is clearly having some improvement. And again, the changes that were made, and but again, I'll leave that to see. So happy to take any questions on the IPRs. Again, some of it will be picked up in the reports from the individual hospitals, but if there's any on the global Luft IPR or women's IPR, I could take those in.
Again. So just on that point, the resilience of the A&E departments after this critical incident has been very impressive. I'd like to think that's where we're going to be in the future, that you said, David.
As we reported at the last meeting, I think the way that was managed and handled was impressive. So to get the organisation sort of back to a level of control, and what realistically from our own assessment could have been within 2 days, even though ICB asked us, purchasing asked us to keep it on over the weekend. was very impressive. And I don't think we've been at that level of ability to do that in previous years. So there's definitely, due to the work of the teams, we've been in a much better way, much better health of ability to be able to do that, I think, this time. So that's credit to the hospital leadership teams.
Peter,
it's just very briefly on that issue. I think that's set up in my report, but it just triangulate. That's exactly what the CQC said, actually, and it rings in my ears. Is that the department, both departments, they work well. They've got ideas, and the system for ED actually works well. So the other bits around it, if only allowed them to work better. So it triangulates quite nicely as well, actually.
Jeff.
In yesterday's Times, there was a big focus on productivity and sort of pre and post pandemic. And I think not for now, but perhaps one of our development sessions, I'd find it really helpful to understand how that's measured, what the drivers are, and is it true that we're actually not as productive as we were before 2020, and what can be done to improve that? Because the figures are quite stark in terms of the millions being put in, and it's not sustainable. I think we just need to understand as non-execs where we come from. And I can imagine the Royal having single rooms doesn't help productivity, but that HMI have better focus just to look at it. Just not now, but at each session, James.
We touch on this, don't we, in the business planning?
Yeah, we've actually got some really interesting stuff. That's a lot of productivity packs that have been shared with us. And what's really clear is, and again, we'll come to later, the shift, if you look at Luft and Liverpool Women's, what you've got, I think what you had, I think Liverpool Women's has been an organisation that's been under significant financial pressure for years, and it's been forced into trimming its budgets, and is financially well stewarded, probably to the point where it almost has affected productivity because it's been stripped back as far as it has. Luft was clearly not very productive, and certainly a few years ago, all we got were examples of how we could be far better at everything. If you look at the latest position for the North West region, we've got one of the highest efficiency targets that we're planning to deliver, and we think to deliver. But if you look at the opportunity, it's quite low. If you look at the workforce ask around the reduction of headcount, ours is already in the negative. So when we see the list of all the trusts, and we'll be able to share some of this with you in the planning stuff, there's 20, 30 trusts who've all got these great big opportunities to reduce headcount. We're already below the numbers from 2022, which is the ask. So again, that triangulates well with reference cost reductions, the workforce controls. But more and more we're getting to a position of where it's becoming abundantly clear that the women's basically has just been in a financial grip for years, and it has affected productivity and to some degree needs balancing back. Luft has done what it said it would do and has reduced a hell of a lot of cost. Has still got some productivity opportunity, but the productivity opportunity that we're being sent for Luft, the total of getting to the best of everything would get us halfway to the control total they want to get to. And that's becoming really clear now, that the gap between that productivity that we could deliver and the number that Luft needs to get to is pretty much to the pound equal to the recurrent new hospital cost that we've still got to see. So it's, every time more information comes out, it seems to be just further illustrating what we've been saying, which is good. Whereas I think a year ago, we couldn't articulate that story around the headcount. We weren't clear exactly where we were. So we'll come on to some of that later, Jeff, but there's some really good examples in the slides that will help with that.
Thank you.
Sarah, please.
Yeah, just coming back to the point around the sort of the recovery from the critical incident. Do our teams recognise that we know that it's them that have driven that? Like, are we doing enough as a trust, as a board, to give that thanks and recognition? Because kind of anchoring back to the point of the stress and anxiety that maybe being more of a trigger for absences and stuff. We are reliant on our teams so much of kind of goodwill and effort that goes into these recoveries. And sometimes, you're from one incident straight into the next, and you forget to pause and think, are we doing enough kind of culturally for that recognition and that thanks to really be felt where it needs to?
Yeah, well, we certainly, so we presented a sort of wrap up look back of it to the 200 or so senior leaders from the organisation just after the event in January. We then presented that onto the staff brief with sort of 500 or 600 people online as well. Again, here's what we found, here's what you did, here's what worked. And then the individual organisations have done that through their exec MD briefings and meetings with staff. So we have done quite a lot of that, yeah.
Thank you. But there is an issue in your report, James, which features in the Liverpool Women's Performance Report about significant progress that we're making on bladder cancer diagnosis, but significant deterioration in other diagnostic ways. I don't know if you want to pick this picked up in your report, Jenny. It's just a question of, is one a consequence of the other, or is it entirely separate to my question? Okay. Anything else on the IP? Yes, Tom.
That's about the CBD cases, which are across both sides and even into the women's hospital. Has investigation these revealed any particular cause? We have concerns about cleaning, about athletic stewardship, or are they all just random events that we've been unfortunate?
It's pretty much the latter. So we've looked at it. Every one of them has got similar. I'm sorry. Go on. So everyone's desperate to answer. So we're all really struggling with this in the sense that, as we've reported several times, the numbers are going up. The numbers are going up nationally, and our position relative is still good. So what's definitely not happening is that our organisation is moving in a way that is saying we are worsening compared to everyone else. So that brings you back to then it's a population problem, and we're not quite sure how and why. There's nothing being thrown up in the investigations that isn't sort of the things that you usually expect. All of the stuff around, the hand hygiene aspects, the antibiotics use, everything that you would expect to be happening is continuing to happen. There's reminders going out all the time. There's post-learning events going out all the time, but the global number is just rising. So as we've said before, we can't really see clearly what else we could be doing in this space, because the actions being taken are the right actions, but the prevalence just seems to be higher generally. So again, we asked David last time to just keep talking to the national and regional teams about, is there anything else that we're missing or anything else that could be done? But at the moment, it's, unless Colin, you've got anything more.
No, we have engaged with the regional teams. So the regional team have been working with us quite closely on a whole project around this particular issue. But as James said, it's quite sporadic. There's no significant themes, but they will continue to support and understand that a bit more.
Yeah. Okay. Thank you. Let's move on then to the site-based reports. We have a different order this time. I have this visual image of the executive managing directors playing a game of rock, paper, scissors to decide the order that we go in, but we start.
It's a different mechanism.
We start today with, I'm sure we don't need to know what it is.
I just choose whoever's upset me most this week.
With Liverpool winning. Jenny, please, that's a big build-up for you.
Okay, thank you, Chair. So I'll bring February's report, and also there's been some questions that have come in from the public, 5 of them, which I'll pick up hopefully during the course of the report. So starting with the high risk register, there were 4 risks scoring at 12 plus at the time of the report, and 2 also on the appendix, which have reduced from 12 to 11. The pack. So I'll take risk 2764, which is scored at 13, and that's in relation to pharmacy and meds management and improvements that have been identified in that area. There are a number of 10 plus risks sitting under that, which we're reviewing through the Hospital Management Board. And there was a business case that came to Hospital Management Board where it was agreed a small investment into additional pharmacy resource could be accommodated this financial year, but the requirement for the full business case in totality was in excess of £1 million. And we recognised the constraints both in terms of availability of workforce and financial resource, and took away how we might tackle that as a group and in the wider last space moving forward. Risk 2770 remains at 13, and that's about anaesthetic cover out of hours emergencies. Improvement work has made the rota more robust, and we've also got improvement work ongoing in terms of a single anaesthetic service jointly led. And the clinical lead for anaesthetics is holding a risk summit, which sounds very grand, but it's just they're getting everybody together really to review their risks, and we'll see how that plays through some of this, which links into risk 2842, which is the cover for consultants anaesthetics on delivery suite. The team reduced this from 12 to 11, having seen improvements in that particular area, but again, that'll be captured through the risk summit. Some of the support for that was involved waiting list initiatives to get people premium payments to get people in, and given where we know where the planning round is going, I think that risk will be kept under review in that context. But 2088 was the Liverpool Neonatal Partnership, and that risk was reduced, as I indicated last month. The partnership are meeting regularly. They met on Monday, and the partnership's working effectively. The build is progressing. We that to be completed around Q2, Q3 of 25-26, and we expect that risk to continue reducing as the partnership continues to embed. Risk 2736 in relation to inductions of labour. I mentioned this last month as well. It's 12 at the time of report, but subsequent to it, it has been agreed to reduce to 9. Improvements were put in place following some sustained deterioration over the summer. We've now got in place a dedicated induction of labour coordinator. We've changed the environment to have a separate induction of labour. And whilst we do strive to have no delays in inductions of labour, we do benchmark well against the regional position, and any delays are reviewed by the head of midwifery. So that risk will now be managed by the division, but we see the data at Hospital Management Board, so we can keep that in our line of sight. It's also reported through the perinatal policy surveillance dashboard in the pack. So I'll just pick up a question that came through around how many women endured delayed induction of labour in the last 2 months. In January, there were 19 ladies who were overdue, and in December there were 27, which was particularly a bit of a spike in December due to staffing numbers. But November before that was, which was 3.7% of the cohort. The data is in the pack in item 71, the perinatal quality surveillance dashboard, if people do want to have a look at that, but that has significantly improved. The next risk is a new risk, which is risk 2989, which is a risk in relation to long-term financial sustainability. This has come on as a 13, and we obviously know all the issues around this, and it's noted on the BAF, but I think given the current planning round, the percentage size of the deficit that Liverpool Women's carries, the national picture, etc., this came up through the Finance and Performance Group, and it's right that HMB have got, the Hospital Management Board have got it in their line of sight, and it's clearly an issue for us aboard, and I know we'll pick up some of that through the planning updates. We will keep that under review as planning goes through the last work as well. So that's it for the risks. I'll move on to the financial position at month 10. So we reported a 10 million deficit against a 10 million plan, and we're forecasted to deliver a full year deficit of 11.6 million. CEIP of 5.3 million was delivered at month 10, which was slightly favourable to plan. We reported capital behind plan. I've caught up with the team subsequently, and they are assured that that will be expended up to the plan. A big chunk of that was in relation to the ambulatory suite that we are building on Crown Street, and we've had confirmation that in the cash flow from the construction partners that will be expended. Cash balance was 6.8 million at the end of the month. You'll recall that we did draw down some cash earlier in the year. We don't expect to draw any down for the rest of the financial year, but we will expect to in 25-26, given the planning position at the moment. So on performance, James has picked up some of that in the CEO report, but some of the things we just wanted to pull out. Never events. So we are reporting 5 on a rolling 12-month basis. As we say, the rolling 12 months is perhaps not the best way to do it. And actually that should say 4 because one should have dropped off in November. Doesn't mean that it's still the themes aren't right and they are higher than they should have been, but there was one that's 12 months, was 12 months in November, and we will have another one dropping off in January as well, given that that was 12 months since the date of that. So there was a question around those. I did report verbally at the event last month. There was a question around what the other ones are. So the latest one we had was an incorrect IUD fitted post cesarean section. The other 3 were 2 of them were retained swabs, tampons and swabs, and one was a guide wire left in situ in neonates. So slightly different themes, but all related to kind of local practice and procedure from the harm reviews that have been done. We maintained 65 week patients, which is great in terms of waiting. The FDS performance, to pick up David's point, that does continue to improve, which is really encouraging and has a positive impact on those patients waiting for a cancer diagnosis. So the FDS diagnosis standard is specifically in relation to cancer, and we changed our pathway back in May around a bit of a one-stop shop. So in the ambulatory suite, which we're expanding, patients can come in and have a different type of biopsy, a papilla biopsy, which can be done there and then on the day, saves them going into theatre for a hysteroscopy, which can also be done in an ambulatory setting. So we've changed the pathway. We can get those people through quite quickly. The other diagnostic standard, not related to that, is more around our delays in that through non-obstetric ultrasounds. That's what's holding us back in terms of progressing those. So it's a different pathway effectively, which is why you're not seeing the linkage in terms of performance improving in one, not the other. Makes sense. Moving on to the NST. As James mentioned, we submitted month six, year 6, with full compliance. Engagement on year 7 is underway. We don't expect that to change significantly in terms of the standards. I just wanted as well to pick up, we talked through the maternity transformation plan. This is what James was alluding to before in planning guidance. So this plan has been around, we're in year 2 of 3 at the moment. And again, it's another initiative around quality and safety improvement over 4 themes and 12 objectives. There are 60 key deliverables within that the trust measures itself on. So we brought those up through the hospital management board and up to board here so that people are aware of what's sort of contained in that and the level of work that is going on within that. It was reported of those 60 key deliverables, 31 were blue, so therefore completed and sustained, 25 were green and 4 were amber. And that was all around PSERP and self-assessments, which was just around awaiting evidence for assurance. We discussed the pharmacy business case, which I've already referenced through the risk. And then we went through the internal audit plan, which was noted as being potentially at risk around the head of internal audit opinion, but we've made some significant progress around that. And we think that risk is significantly reduced. So I'm just also going to pick up the questions that came through the public that I haven't already picked up. There was a question around fill rates for staffing in maternity, gynaecology and neonatal wards in January and February, and that these figures used to be published in papers and that perhaps they've been missed. They're not in the pack. They are reviewed monthly through the quality group and through the IPR that goes to the quality group, so the performance report that goes there. There are no issues escalated through that through the fill rate data, but we will make sure that that information is available, and I'm happy to share that data. Next question was around the risk that the trust can't achieve long-term financial sustainability. So the risk that's gone on basically, and the question was, is the board in contact with other maternity providers to jointly request better maternity funding? James mentioned at the start that maternity tariff has increased, is proposed to increase by 11%, gynaecology 15%. And while that 11% is really welcome, it's about £8 million for Liverpool Women's. It doesn't go anywhere near the size of the gap that we carry. Just about covers inflation since 1819 when the tariff was last updated. It doesn't take into account the Ockenden changes that you've heard me talk about, 60 actions for the maternity transformation plan. And there's been some significant changes in the model of care since the tariff was last updated as well. We deliver far more babies through caesarean section, 45% compared to 27% in 2019. And you'll see our inductions of labour going up as well, which is, again, a more intense model. So we fed all that back to the tariff team because there was a consultation around that. And our Director of Midwifery links in with MPs, Parliament, national lobbying. She's very, very good at raising that awareness and issues around tariff. Picked up the Never Events one. And the final question was around equivalent substantive staff vacancies. I think that was pulled from the IPR. Which departments are they in and are they being advertised and where? So that's the net figure of vacancies that we carry, and it is across a number of areas. From a nursing and midwifery perspective, there are no maternity midwifery vacancies, and as you'll see through the reports, we don't carry any maternity midwifery vacancies. There are some posts within the neonatal partnership which aren't filled, and that's just in terms of the progression of the plan itself, so not a concern over there. And again, no holding back on nursing vacancies or controls there based on safe staffing levels. So it's just a fluctuation of as people leave and as we recruit, and times to recruit, or around also in terms of they're not advertised, because we look between ourselves and see what we can do in terms of internal opportunities across each other as a group and over last, but there is no freeze on clinical recruitment. So I'll stop there. Take any questions.
Questions, please, Jackie.
So, thanks, Jenny, for that. just around the question about the staffing numbers, because I know we've probably seen them in a lot more detail in previous boards, but I think the requirement nationally is twice a year to do our safe staffing, and obviously we do birth rate plus and we check all those things out. So within the maternity champions work, I see that and know what's going on. And I know I've raised concerns about sickness and absence in maternity, and that is being looked at, but I just wanted to assure the public that we do go into that level of detail. So I think that's important. There's two questions, if I may. One around the NEB events, and you've talked about doing additional reviews and that. But I suppose I'm looking for what are we coming out with? What are these themed reviews coming out with? Is it human factors, or is it a push to push more patients through when we're not being as productive, or being too productive and not being putting the safety bits in place? So just to understand that. And then the other thing was around, if I may, was around the overdue risks and out of date policies. You put assurance not assessed. And I'm just wondering why, because I know we had a big issue with out-of-date policies. So the two things, if I may, never events and then the policy.
So not all the learning is concluded on the never events, particularly the more recent ones, Jackie, but I think you're right, we can bring something through around, they have been identified as individual local sort of practice. But yeah, we can bring something through around the learnings around that, if that's helpful.
I was just going to mention our conversation the other week, because back in 2022, we had a higher level of never events in Luft, that were all procedural safety type human factors issues. So Jane and I had a great conversation last week to follow up with Diane about, would it be helpful for Neil, who led some of that human factors work, to perhaps have a conversation over at the Women's and say, is there anything that we could share around that? So there's nothing standing out in the reviews that we've seen so far, but it couldn't hurt to try and do some of the human factors work.
I think so, because I think that's definitely the way to go, because there's always going to be something in there that's not gone right, that's made something happen that should never happen.
And in terms of the overdue policies, they do fluctuate, and there's a number outstanding at the moment. What we did through the meeting was around, of those overdue policies, ranking them, tiering them in terms of people thinking the issues not going to impact us, and ones that we can say, actually, as we're moving forward to harmonising our policies, we can just hold that policy rather than update and move it, because we know we're going to be changing some of those, and others will be more pertinent that we do just need to update rather than wait until that harmonisation piece. So we didn't assess the overall assurance. We recognise that we've got a number out of date, and we want to go and do that piece of work around prioritisation and making sure that those ones that are really sort of pertinent to patient safety or SOPs or whatever are prioritised over the more transactional ones.
But you're comfortable as to where you are then, yeah?
I'd rather it was better in terms of the number of overdue, but I think they've got a plan to work through those that are overdue, because as some come off, as you know, Jackie, some come back on. So it's just managing that.
Sure. Thank you.
Thank you. Question? Okay. Yes, Daniel and Sue.
Yeah, this may be my lack of understanding of the metric, but when I was looking on the IPR and it raised the stillbirth, was 8.2 per 1,000 total births, compared with 5.24 in December. And then when you go onto the perinatal dashboard, it then talks about 3 in month 10, which is below the national framework. And I was trying to work out, on one it says watch and be concerned, and the other one's saying don't be concerned. Is that just the way the different thing? I can see Sarah.
I'm smiling. I know. So
that's usually your question.
Do you know, I was going to bring it out in the report, and I didn't, so I will do it now. So there are 8 on the IPR. In the perinatal dashboard, there are 3 number 4.6 per 100 per 1,000 stillbirths. The IPR is 8 per 1,000 stillbirths. The perinatal dashboard is 4.6 per 1,000. The reason they are different, those two using the same denominator effectively, is because the perinatal dashboard adjusts for congenital abnormalities, so babies that are stillborn as a result of that, whereas the IPR just takes the total stillbirths, and that's why the data is different, and the 3 is just the whole number.
So is there any significant reason why the rate has gone up from 5.24 to 8.2 in a 2-month period?
It just fluctuates around, just because some of them are from a raw point of view.
Yes. Well, it's raised, but I think it's back to that. It's still within normal variation limits, so it's that bit that we've got to but
All still better reviewed.
I think the bit that we've not come back to is actually looking at the range, so
Yes.
we're clear on what the statistical differences are, because we do still have the peak at 15, which was an anomaly. So we think there's that right sizing what the statistical
the IPRs are being put together now into the single version for April, so we're going to address all of the range limits. SBC chat. I think your point about that one-off number skewing the ranges is an issue.
But I think just for reassurance, from a maternity perinatal dashboard point of view, we are well within the national benchmark.
What would be useful, because it has come up, and thank you for it not being is just when we're stating that maybe in the report, to say why there is a difference, because it is, you have to kind of constantly remind yourself why there is. But there is also, I think, for our hospital, there are referrals for babies with congenital issues that are referred to the women's because of our care, and therefore that can skew. So where those differences are exacerbated, it's probably because of more mothers and babies being referred into the women's, and therefore that exacerbates that overall. But we just need to get the language around it right, so it's easy to.
Oh, please, your maiden question.
Yes. My question's around internal audit opinion for the year, and if you indicate there's a risk around that, could you just provide some assurance around what you've done to de-escalate that?
Yeah, so earlier in the year, as we were approaching the year end, the number of outstanding actions in terms of internal audit and reports was noted as high for both Luft and Liverpool Women's, and that was putting at risk the head of internal audit opinion. So in terms of dealing with that, we've basically just got people to read in which they're responding to the actions and the outstanding reports for internal audit, and we've moved that forward in terms of closure of high risk actions, and also closing down those outstanding reports that we've just done 2 in the last couple of weeks, so that the internal audit manager has enough of the information to be able to give that substantial opinion. Liverpool Women's historically gets a substantial opinion. It's just that kind of running as we get to the year end to make sure we've got everything cleared off in time.
Are you happy with that?
Absolutely, yeah, very confident. Yeah.
Thank you. So, this is a marker down for a future discussion. I don't know what we do. We talked about the work going on between, I think it's essentially the Royal and the women's sites around anaesthetic cover and so on, which was always featured on the Liverpool Women's Risk Register, and we now seem to be working in a different way. It'd be good at a future point what learning we're getting out of that and what further opportunities there are for us to do better together than we were doing previously.
Well, nicely teed up. The Strategy Partnerships Committee in I think it's 2 weeks will be presenting the hospital-based improvement plans, and each of those describes. So we had this discussion just earlier this week. So where there's an ambition, for example, to have a single anaesthetic service to support women's out of the Royal or MEC team, etc. Which of the improvement plans it sits in? Because as we get to April, we're going to be reporting improvement plans as hospitals rather than only for the organisation. And each one of those will show where there's joint working between 2 hospitals to solve the problem and have tracking mechanisms in it to see whether it's done. So it should give us a level of greater assurance around these are the 2 or 3 things we're going to do here to improve patient safety at the women's. That's about the Royal and the women's working together. And then in the same old style that we've had of improvement plans, here's the metrics that will tell us it's working. So I think that will really help us be able to see that. Excellent. So we'll go through that in a couple of weeks.
Thank you. Look forward to that. Right, let's move on. Next on the order is Broad Green.
Broad Green. I'll just mention 2 bits. There's no risks of 12 or above at Broad Green. So financially, Broad Green is reporting 0.19 million better than the plan, and will have achieved the CIP for the year. The issue is sickness absence at Broad Green, and that is impacting on the financial position because we have had to start using some agency nursing at Broad Green, which we do not usually need to use. So sickness absence in January was above the control limit at 9.51%, and that is the highest it's been in 2 years. I've just received the report this morning, actually. So sickness absence, the main reason is stress and anxiety, and it's not work-related stress. It is there is a large number of people off with situation related to stress and anxiety. What we have discussed is, I think, we're going to review our approach to supporting staff with sickness absence, and particularly around some of the facilities that Heart and Chest and the wellbeing approach they take supporting their staff. So we're meeting this week to have a look at what we've already got in place for those staff and perhaps how we could approach it differently, because whatever we're doing obviously is not having the desired effect. So that's the real focus at Broad Green over the next couple of weeks. I'll pause there if there's any questions on Broad Green, but that was the main focus at the Hostel Management Board.
Any questions?
Can I just?
Yes.
It just would be helpful, I think, perhaps for the board to be aware of the changes, because we've obviously described before that whether it be this meeting or the next, because we report a month behind, it might be the next will be the last Broad Green meeting. Broad Green is obviously going to be co-joined with the Royal within its management board, which will allow us then to, over time, bring Heart and Chest Hospital into the similar framework. So do you just want to say a little bit about how that's working and what's happening, where that's up to?
Yeah, so from 1st of April, Broad Green will come into the Royal as a division. So we have 4 divisions at the minute: medicine, surgery, St Paul's, dentistry, and we'll have the Broad Green division. So we've communicated that and worked with the hospital leadership team to do that transition. What we will do then, though, is review, because I think there's a better way of structuring the divisions to maximise patient pathways across sites and look at our link it with our integrated partnership strategy. So we're just working that through at the minute, and then we'll go through a consultation with the impacted. So I would expect by probably May, June, we will have then just changed the divisions across the Royal and Broad Green. I can share more information on that once we've formed that structure. So initially it'll just come across as the Broad Green division, and then we'll develop that.
Thank you. Any thoughts on board?
So,
yes, Sue.
Can I just pick up the point on stress?
Yes.
And I know it's been mentioned a couple of times, the escalation of people being off with sickness. It's related to home situation, which is often the case. Do we have any more intelligence in terms of what that specifically is? Is it financial? Is it responsibilities? And what are your timescales in terms of dealing with that? Some additional support.
Yeah, so at the minute, when I've read the review, some of it is long-term health issues of, terminal illness for partners, etc., that they're dealing with, and they've got care and responsibilities, etc. Some of it is abuse, domestic abuse. There's quite a lot around sensitive issues like that. So there's quite a varied issues going on, complex issues for people. The timescales, that's what I need to meet and work through. Sorry, I should have said I've only just been in Broad Green for the last couple of months as the managing director. So we've been working through this detail. So that's what I'd be looking at next month, being able to tell you what that plan is and the timescales and what we're going to do to try and support some of these team members.
Thank you.
For Sue's information, at the last board, we talked about, for example, bringing the citizens advice system into the organisations to be located within the hospitals, largely to support patients coming through emergency departments who have multiple issues that aren't just to do with health, but also then as an access point of staff. And we do think, particularly on the financial aspects, particularly that might be something that would help us. So we're just trying to figure out how we can do that, because there's a cost associated to it. But we think it'd be a good thing to do across the organisations, and potentially another good example of if we could do that at Broad Green, Royal, Aintree, for example, that could benefit Bridge and Heart and Chest, and we could share those.
Yeah.
Thank you. Heather, please.
Just for Sue's benefit, probably really that the demographic of the staff group at Broad Green is quite different than it is at the other hospital sites. It's an older workforce. It's a predominantly majority female workforce. So we do see the health issues that come with that that group of staff quite different than we do on
I know we've already used up our board quota of time on car parking issues today, but it does remind me that we talked last year about this transfer of car park ownership. Is that now a closed issue? We were sort of going into arm wrestle with the previous owner of it all. Is all that done?
Well, it's a closed issue that we own the car park, but it's not closed with the previous owner. We're in a mediation process.
Okay. put that back to us about 2029 then.
Well, it seems to be taking that long, isn't it?
Yeah,
It's been about a year.
take forever, these things. Okay, thank you. Right, let's move
Okay.
on. Royal, please.
Royal.
Natalie.
So Royal, significant urgent matter we discussed was around breast cancer faster diagnosis standards. So it's been on our risk register a while due to the level of vacancies we've got, particularly within the radiology teams. Further sickness absence meant that we had a significant deterioration in performance in January. So we only achieved 18% against the faster diagnosis standard in January. We did put a recovery plan in place, and we put additional insourcing and additional clinic support by our own staff in place. When we did the HMB, we had managed to get it back up to 67% against the standard, and we have a recovery plan, so I'm expecting us to be meeting the standard in future weeks. We are bringing back to Finance and Performance Committee next month a more longer term sustainability plan, because we can't keep going with obviously premium rate provision of the activity. And we did successfully recruit 2 new breast consultant radiologists last week. So we are making progress in that. We then went through around the financial position. I know we'll come on to it when Rob does the finances, but the Royal, very similar to previous months, but in month 10 we did see more pressure on our expenditure budgets, primarily related to pay. That was due to the additional areas we opened to respond to the critical incident, and we did put additional weekend medical cover on, pharmacy support, etc., to make sure we could respond appropriately to the patient safety concerns we had in January. So we are expecting that to come back down when we see the month 11 position. CIP has not changed significantly from the previous months, that the Royal were forecasting £25 million CIP achievement, about 90% of that recurrent. That hasn't moved significantly. However, we have developed significant plans, which I think we're going to go on to in the private board, around the CIP plan from April onwards. So we can update on that later in detail around the schemes. Just touching then on urgent and emergency care. So we've already referenced in the IPR, we did see a significant improvement in ambulance handover in January. So we're averaging 44 minutes. The latest position I went through for February, that's come down to 39 minutes for February. And we've met the ICB devolved targets to each trust for improvement, and we'll have met our target that we were given at the Royal for February. So we did still have 290 ambulances that waited over 60 minutes, but that was a 242 less than we had in December. So a significant improvement, and the triage and time to see a clinician were maintained. What I would say for the Royal is, whilst that has improved, February has still been challenged. So nowhere near critical incident status, but we are still undertaking corridor care and boarding across the ward. So it is still a prime focus for us, because we are still pressured. Just picking up on the not meeting criteria to reside, what I don't think you see in the overall data is there has been a really significant shift from patients that are waiting for a pathway 3 long-term placement in a care or residential home to those that are waiting for a pathway 1. So we're now at the lowest I think we've ever been for patients waiting for pathway 3. That isn't necessarily because we are discharging most pathway 3, it's because our work we've been doing means that we are not now declaring them as long-term care. They are being declared as fit to go home with support, which, if everyone remembers, that was the prime aim that we need to do. So what that is doing now is shifting the focus that we need and the improvement plan to the pathway 1, which is a different I suppose focus, because it's less linked to care home sustainability and now more linked to around our care home processing and what social support we have available in people's homes, packages care, etc. So when we bring that report next month, we can go into detail on that, but that's sort of the detail that's sitting underneath that pressure. So at the minute at the Royal, it's 10 days to get a pathway 1 patient out against a national standard, 24 hours. So that has deteriorated, and that's why we've still got the pressure at the minute. Discharge pathway. At the Hostel Management Board, we just touched on the key developments in month for UEC. So we've expanded the walk-in centre. We've got 2 more consulting rooms now over in the Lyndon McCartney Centre, which is enabling us to support 24/7 primary care streaming, which we've been doing since mid-December in there. So that's had a significant positive impact on the emergency department. The gastro assessment unit, which we stood up 6 months ago, came and showed us a review of their metrics, which was really positive. They showed us how the introduction of the assessment unit has reduced length of stay on the 2 gastro wards, and they are now pulling 25% of their assessment patients directly from ED or same-day emergency care. The renal virtual ward is not just for the Royal, it's for both sites. It's going live in March, so we got the update on that. And we reviewed the primary care streaming figures, and at the minute, 12% of our ED attendances are going across to Linda McCartney's to be dealt with by primary care. So we're seeing a significant impact on there. Just touching on the IPR and the metrics we won't have been through. So the couple I just want to pull out is we have had 2 never events reported in the report. They are 2 that are within radiology. So they occurred on the Royal side, but the governance and management investigation obviously sits under the Aintree side. There was no harm reported to the patient. That was not me pushing that to Aintree, by the way. Just stating where it's managed. So we're looking at that. There's no serious harm caused to the patient, and the investigation's ongoing into lessons learned from that. We did have 1 MRSA bacterium reported in January. That occurred in renal, and it was around IV line management. I've just stated in the report again, Aintree have had a very similar case. When we've looked at them, very similar issues. So there is a shared investigation report taking place so that we can ensure the lessons learned are shared across both sites. And from an elective perspective in the IPR at the Royal, we have no 65 weeks, and we have reported our 5th month in a row of decrease in 52-week waiters, so that's positive. The DMO1 is our challenge, so we're at 8.9% against the 5% standard. You'll remember it's on my risk register. That is being driven largely by endoscopy, but we have a trajectory in place which we have met, and we're expecting to be back at 5% by the end of March.
Can you just explain DMO?
Sorry, this is the 6-week diagnostic test as part of what should be an 18-week pathway. If you remember, when we stood down the premium pay arrangement, we lost activity in endoscopy, which is what's caused that backlog to occur. I'll just move on then. We reviewed a number of business cases this month in H&B, so linked to that endoscopy risk. There is a case we reviewed and approved, which is going to go to execs a week on Tuesday for gastroenterology focused on endoscopy capacity. So at the minute, a large amount of the trust premium pay is taking place in gastroenterology. It was insourcing, and that transferred, but it's still a significant WLI is taking place. We've done a demand and capacity review, and a business case is coming which proposes an increase in substantive staff to deliver the same level of activity but at a lower cost base than we've been delivering it for the last 2 years. So that case was supported by H&B and is coming to execs. We also reviewed the case for the digital investment in nursing support for the EPR implementation. I know that's going to come to the management board, so we supported that. And a similar case of gastroenterology. Urology is the other area we continue to use insourcing to support us. They brought a case again, similar on how we can reduce the cost base, but expand our substantive workforce. That just needs a bit further work, and then I expect that to come to execs in the next month. And then finally, on the risk register, the Royal at the minute has got 14 risk scoring 12 or above. I'll just touch on the changes. So we've got 1 score risk which is new in month, which is 8607. So this risk relates to emergency general surgery. So this is the risk around the on-call provision. At the minute, we have 6 consultants who are either off sick or have got occupational health advice that they can't participate now in the on-call rota. That is having significant issues on the on-call provision. So we are covering that on-call rota, but obviously financially we're doing that at a premium. Through Right Patient, we have reviewed the on-call system at the Royal, and we've just signed off a 12-week trial of a new provision, a new on-call rota, which will hopefully support the consultants around this, because at the minute they work 2 rosters and there's a lot of issues around the sustainability of that. So I'm expecting once we've done that trial, hopefully there'll be a recommendation of a change in the on-call, that risk reducing. We've got 1 risk which has increased in month, which is 7413. So this is a risk that was raised by the clinicians in the diabetes service, and this is around the provision for diabetic foot. This is the therapy provision for diabetic foot patients. They raised this risk due to some clinical incidents they had seen in clinic. The therapy team have produced a review and shown me where we sit benchmarked against NICE guidance for seeing patients within 2 weeks, and we are not meeting the standard on the Royal site. So we have raised the risk, and I'm comfortable it needed raising. Again, this is a service that currently sits and is managed centrally under Aintree. So I've met with Becky Hanlon, and we've got a corporate review taking place about the provision, and I expect by next HMB, we will have a report to HMB and a recommendation of how we improve that. And then finally, we've reduced one risk, which is the general anaesthetic capacity for special care dentistry patients. We've got controls in place. We've managed to reduce the waiting list by 6 months at the minute. So it's still not where we want it to be, but I'm confident the controls are having an impact. So that's just been reduced to 11 and we'll still monitor that through HMB. I won't go through all the other risks because we have touched on them in previous months and they've all got narratives. So I will just take any questions on the other risks if they need to raise.
Thank you.
Same 2 week wait.
Sorry, I was going to ask you, but I was just.
It's the breast.
Yeah, it was a noticeable deterioration in the IPR on the 2 week wait because the statistic does.
It's the element of the breast faster diagnosis.
Thanks for that comment and a question. Maybe the question's not for you. The comment. I wasn't having a go about no criteria to reside. I'm just trying to say. No. Just on urology, which seems to me to be a long-standing, fairly intractable problem. It seems everybody's changing their fiscal rules to try and create some financial headroom. Are we pushing the investment in urology that we need? It's been a long-standing base and it just seems to me underfunded service. Are we as flexible as we can be in terms of our understanding of internal investment capacity stretched over a period to give ourselves maximum headroom? Because we're not going to have the cash, are we? We're not going to be able to create lots of cash in terms of investment capacity. Are we being as creative as we can be?
So I suppose this is where I think Rob has worked with us. So I have got the budget within the Royal site, but I'm spending it on the insourcing and WLIs at the minute. So I'm not, I suppose, asking for investment. What we need to do, I'm asking to put that budget, less of that budget, into substantive staff, and then potentially create cost efficiency as part of our CIP programme then for the difference between substantive and the insourcing. So I think there is an ability for us to be able to fund these cases, but that's what needs to be worked through.
Not just quickly on that, as you know, the organisation's it's taken us 2 years almost to figure out how many people we've got, are they properly job planned, are we getting a return on contracts, etc. And we're now entering this 3rd year, which is we've now got everybody's job plans clear. There is clear evidence within that we should be getting more out of some of those job plans than we're getting. So on every case, urology being an example, we just need to assure ourselves that actually we're getting all of the PAs that we should be getting for what we're paying before we then put additional investments in. And that's a delay tactic. That's just we've got to make sure that we're getting the right efficiency. Now, sometimes that's, just to clarify, that's not about clinicians not doing what they should do. Sometimes that's, we haven't got enough theatres or clinics, so they're flexible session, they haven't got anywhere to go. So we've just got to make sure we're getting the right value out. So we've just got to this point from last year with the PwC analysis where we've now got some really good evidence that's coming out. Better team are now leading that this year across all the specialties and then feeding those packs to each of the hospital sites to say, urology, you're fine, off you go, or orthopedics, again, I'm using this for example, you should be getting 30 more sessions out of this. So you get that first and then you get your investment case. So we just need to tidy that up, like, because there was a risk that we would continue to employ people that we then couldn't get into a clinic or a list sometimes.
I think the other thing that's helpful, Mike, the case, the pushing them back to Jeffrey's point and thinking about productivity. So urology, in their case, they've opened Ward 13 on this site, which is a procedure clinics. Some of the cases to fully staff that so they can pull procedures out of theatres and they will do them here in clinic, which is all part of the Right Procedure, Right Place programme. So there's some really positive things around productivity gains that are in these cases as well, which I think we need to focus on.
Thank you. Any more questions? Yes, Jackie.
Thank you. Natalie, can I just ask you about on the performance bit around the MRSA and then the e-news compliance? Because obviously they've been part of improvement plans and aseptic no touch technique, and obviously an MRSA in a renal patient could be a devastating consequence. So is it around training or is there some other issues that you think are causing the problems?
Yeah, so the e-news compliance we raised at HMB because it's about the 3rd or 4th month that we've seen it drop. So that's going to be a particular focus at quality and safety, and we're going to get a specific report on it to next month's HMB. I think the feeling was, I think it was a bit of the pressure across the site as people have just not had as much of a focus on the recording of it as they should have done. So each divisional nurse is picking that up in the ward managers forums following HMB, and I'm hoping we'll see a quick return to that in-use compliance. The MRSA bacteria, I was picking up with Lindsay and Jen this week. I think there's a thing, it is around a lot of it, me and Peter talked yesterday, is around cannula management and the training, and I think that's what's going to come out in the lessons learned. I don't know, Pete, if you want to come in, because I know you've been close to this. And...
Yeah, no, I'm happy to. I was going to bring up in my report, Jackie. So actually, Intri have had a number of MRSA vaccine, as you've seen in the IPR. Of that number, 3 related to cannulation, all slightly differently nuanced, but basically related to cannulation. So one was a cannula went in externally before the patient arrived at the ED, and then was left in and not, and I think should be removed. Another was a patient who was not overly compliant with the decontamination therapy, and understandably, because it's not easy, but the reaction to that probably was less than 3 nantin. And then another one where a difficult cannulation, and what do you do when you are struggling to get a cannula in and avoiding repeated attempts? And I think I've just been speaking to Jen about that. I think development in our policy around what advice are we giving to our particularly junior medical staff about when there's enough attempts that can be enough. And so I think there's a number of different issues all relating back to IV cannulation. It's classic for MRSA, as you will well know. So the two teams of both Lindsay and Jen are going to work together for a cross-site broad as well. Absolutely clear advice about what we do and how we manage people. I think that will hopefully make them.
I'm just a bit anxious because that can very quickly escalate.
Yes,
when you've got a real MRSA issue when it's getting it back under control, isn't it?
Yeah, and just for absolute clarity, I know there's another one at the Intri coming next month as well. So there'll be another one in the IPR next month. Cannulation again, that's the external cannula. So there's been some real attentions taken.
Jim, please.
Well, Chair, if I may just make a point about e-news, because we are about to start piloting continuous monitoring with biosensors, which should, one assumes, make this much less labour intensive, much more reliable in terms of real-time monitoring. So I hope not too distant future we'll be able to articulate this issue in a very different way. And if that works, in the early days, the productivity piece that potentially transmission. So it's a really Neil Jones credit for the work he's done looking that up, but we're ready to go now.
Excellent.
Yeah, just a quick point. Yeah, just for assurance on the EUs, are we assured that it's not a result of boarding patients not being?
No. Yes, I'm sure.
No, yes.
Yes, we do specifically look to boarding patients. They're recorded the exact same way on the wall.
Right. And that's
there's
both sides. So if anyone's boarding, we're absolutely certain everyone's getting their EUs.
Yeah, there's no issue.
Okay, all good. Thank you. So done. Let's move on. Laboratories, Rob.
Thank you, Chair. Yeah, the report is out, our meeting held on the 20th of February. Happy to say that no issues above 12 to raise to the board, but a couple of key points. Our main concern remains issue risk 8522, which we raised from a 10 to an 11, and this is around the industrial relations we mentioned last time as well. We met with the regional officers to try and understand the unrest that appears to be in the microbiology department, and seems to be, the root cause seems to be a concern about potential understanding of staffing levels and comparability with other sites. So what we've agreed to do, and happy to report that we've secured back, is they asked for an independent review. We've managed to get the chief officer from NCA pharmacies to work with us and look at that. So hopefully that will ease some tensions and help give that objectively. But it remains an 11, and there's still the option for them to take a ballot on industrial action, but hopefully to avoid that. Just a couple of other key risks to note. A couple of 8172, the LIMS project, which is being run out of Cheshire and Merseyside. We are a bit concerned about the resource that's being directed from the centre to us. So we've put our request in there's a business case going through the process, and we wait to hear that. But we feel we need support to successfully deliver that programme in the year to come. In terms of histopathology service remains under stress because of the demand, but we did secure £300,000 in aid in a grant. So we've put some new kit in that hopefully will start to, we'll continue to improve automation and start to see results March onwards. Cellular pathology, we approved in principle a draft business case to move the department onto a purpose-built Wavertree location. There's still some finalisation, particularly around the finances and the rent and the structure of the deal. So it's not yet come through executive directors, but in principle that will come shortly, and then subject to review there would come up to the power. But that could be a really exciting opportunity for us. The only other items I really wanted to pull out in terms of the risk is 6678, which is on here as an 11 related to Clinicis WinPath, which we've talked about before, is the system that was not consistent with the rest of the organisation, and we were moving over to Telepath and was unsupported in January. And really pleased to say on the 4th of February that successfully moved over to the Telepath system, which really gives us resilience, gives us consistency across the trust, and really help from the Aintree team. So that's been a long-standing issue that we should really pleased about getting over the line. And finally, just to note that the finances remain on track. We're £800,000 better than planned, ahead of the CP by £100,000. Expect to overachieve by at least £500,000 by the end of the year. They're the key things I like to know.
Very good, thank you. Any questions? Just
a point that I'm constantly perplexed with SDL in the sense that if you go back to a couple of years ago, the people metrics were on the floor, weren't they? 40% of people getting appraisals, or the people metrics in the latest report are all statistically better than ever expected in terms of people getting appraisals, mandatory training, all the stuff that we know is important. The leavers rate is really low. The retention rate's gone better than ever. Yet there's still a significant amount of unrest. It's almost like all the right things are happening, but people still aren't happy. So this discussion with the unions and external review will be really. We're clearly still not quite getting to the number one.
So absolutely right, and it's a wicked issue because even retention, as you say, is actually going up, which is bizarre. So what we've tried to do is to kind of isolate what are the individual areas of concern. So we've got 3 task and finish groups, one around chemistry IT support, which everyone will be retrained by the end of March. One around the ventilation system. We've secured some new kit that's going to be the first in the UK, but it's used in Europe, and hopefully we'll resolve that issue in the microbiology. So we're trying to break it down into chunks, but it is a perplexing issue.
Thank you. Got Heather, then Mike.
Yeah, just to back Rob up my team, that there's about 5 pages of interventions that are going into LCL from an HR and OD perspective. I think one of the things maybe we need to, once that review's done, I think there's possibly some building of relationships between middle managers and trade unions. Yeah. I think that is where the nub is, which is feeding the trade unions' continuation of this. So I think we're going to have to focus in that area.
Thank you.
Standard theory of revolution, most dangerous time for bad government is when it begins to reform it. So, just in terms of, we're all not that long. Substantive medical director process, is that underway?
Well, it's the ex-incumbent that left the organisation, as you're aware. John Brennan, the Deputy Medical Director, is standing in and ably doing so, actually unearthing some issues that goes along
and then that process will continue. It will be relatively easy.
Thank you. I would encourage, thanks Rob, I would encourage Sue and anyone other NEDs haven't been, you could go into the laboratories facilities on the Royal side. Indeed, the labs on Crown Street side. Remarkable science that's going on. The learning you can pick up from extremely impressive. So there we are. Let's move on then, please. Entry, Peter.
Thank you, Chair. So the paper is there. I'll just talk people through it. So this month there are 10 risks greater than 12 on the high risk register. There's 2 at 13, which is 2 less than last month. With the operational side and 65-week wait and the ambulance handover risk have reduced down slightly. So reason for covering this. 2 at 13 relate to the critical care risk, which, as you know, has been there for some time. Actually, it's on progress now on that risk. Jim and I had a very helpful meeting with colleagues at the ICB yesterday, and I think there's an acceptance now that this is a multi-level, multi-dimensional problem. In other words, there's different levels of system you can look at, plus also there's a number of different moving parts around critical care that are impacting, particularly at the entry site. The conversation was positive, and some I'm going to link in now with the critical care network and with ICB support to look at right sizing, if you like, or making sure that both the critical care units at Royal and Aintree are right sized, particularly entry pressures, which is around level 3, as I reported. Also, I was heartened by the positivity at looking at new ways of working around critical care. That's done some of that work at Royal and the Ezra. As we know, we've done some work here with the ventilation in inpatient centre, but I think there's a lot more we can do in that space of level 1.5 care, if you like. So some positive discussion yesterday with the ICB about really trying to prioritise some of that as well, so that we'll get necessarily a costly exercise, but it will be a more transformational exercise to get the critical care sized for entry. So positives in that, and I'm hoping that will bring that risk. Now we've got some controls in there, so we'll have this discussion next month at HMB. There's 2 new risks. One is around around orthogeriatrician support, which links into another risk which is slightly lower, which is older person's perioperative care risk, where the entry provision is not as strong as the Royal provision for historical reasons. Then I think links into again some work that Nat and I want to do together around frailty. So there's an action plan developing around how to manage that, but I think it's a risk that is scored at 12 at the moment, just new in our minds. But that there's a risk around not delivering the plan in orthopaedics, which links a little bit. It's always been there. It sort of links back to the critical care incident and some of the changes being made to make sure that non-electives were prioritised. But we're working our way through that, and hopefully that will come back. A couple of risks are reduced, particularly the theatre risk in terms of because we're recruiting into staff, and that's gone very well, and hopefully we're not going to be able to stop insourcing, so that risk has come down. And also the MFE risk I reported is sort of flicks up and down just around the consultant staffing, because of the specialised nature of that unit. Have managed to recruit some people now, so that risk comes down, which is good. But we're going to move the actions for that risk into the E3 pillar of the group transformation plan. And so I'm hopeful the cavalry are already coming up ahead now with some transformative work about how to substantively ensure we've got the right team in for MFE. And let's go through some of the other key areas to highlight. So UEC, we've had some of these discussions. I think, coming back to Tom's point, post-critical incident, what we have seen, I think, in the way I sort of look at this, the front door bit of UEC has been substantive improvement at the entry site, and that links back to some of those interventions I reported last month. So our Sergio is the increasing use of our same-day urgent care units, our continuous flow policy, our ambulance handover. So these are these key interventions we've been shifting in, and what we've seen as a back of that, I think, is that the ambulance turnaround times have reduced by 34 minutes, and there's 400 less 60-minute ambulance handover delays in entry last month than it was substantive improvement, and you can see that on the IPR with the big reductions. Also, just want to highlight, I think this is in response to some of the changes we put in, that the time to treatment in 60 minutes is about 72% now in entry, and that's way above the control limit, so statistically significant. And as we've highlighted, 15-minute triage and family being also important. So the front door looks like it's made some substantive improvements in the last month. The key challenge, as we've highlighted, and I won't repeat all of it, is on the discharge and no criteria to reside. But if you look at the IPR and the entry, no criteria to reside numbers might are statistically worse. You get points above the median, although it's sort of coming down, but it is technically a deterioration over the last 10 points. But within that is the detail where, as Nat has described, there has been an appropriate, this is what we want to do, because it's right for patients as well. It's less patients now being planned to go into long-term care. It's much better that patients, in terms of conditioning and for the long-term future, that they are supported back into their own pace of residence if we can. So we're doing the right thing there, but that's a different discharge process, as Nat has highlighted, and it's sort of brought to the fruition some of the changes that we need to get into in that sort of home discharge pathway. As James has said as well, there's agreement between ourselves and care with the direction of travel now, so that will be coming over the hill. But as Nat has said, it's 10 days at Royal to get a pathway 1 home care patient. Home at Royal is 8 days at entry, which is still way above the expected delivery. So a lot of work to do. I've also said in the report that we have seen an increase in category 3 pressure ulcers, which is a concern for us. We've also seen some other potential areas where harm that seems to be related to, say, patients. So we have a high number of patients on a deprivation of liberty pathway as well in entry. I think all related to can't get home. And so what I've asked for in the paper coming back is to look into that to make sure that we are doing everything we can to prevent the harms that we potentially can see. We know this is associated with harm with long stays in hospital, but let's have a good look at it. So that paper's coming back next month, particularly into those category 3 pressure ulcers, to make sure that we're doing everything we can to prevent those, but also any other harm that can be associated with long stay to make sure we're not mixing. So that paper will come back, and I'll bring that back next time. Just moving into the elective side of entry, the 65-week wait, as we've discussed, sits within the ENT. Previously, we had issues with orthopaedics and max scats, but that they have been dealt with. So the risk really sits now in the ENT department for patients who are waiting for more than 65 weeks. At the time of our HMB, which was probably 2 weeks ago now, there was 312 patients waiting on a 65-week pathway. We had, as I reported last time, we had gone out to a insourcing company called Asset. They were reporting positively back at that stage of HMB that all those patients would be dealt with. Like all great plans, there's been some issues with it, and so Asset have handed us back some patients that they cannot deal with because of the complexity or related issues. So there's a number of patients, therefore, that we're now having to manage ourselves that we had hoped Asset were managing. So our focus is now on those patients. Currently, there's still approximately about 150 patients waiting to be dated. We're managing that with Beth's team as well, support and help. In making sure that patients get a date for their patients. The risk then sits with those who need to come in for treatment. Probably a 27 patient risk currently of patients who need to come in have a procedure by an ENT surgeon that we're managing on a daily basis. But we're hoping still we can reduce that down to where we want to be, but there's still some risk sitting in that in terms of delivering that by the end of March. But a lot of work going into it, working with Asset and managing the patients that Asset can deal with. I'll just go through the IPR. I think most of this we've covered. So the CDT I was going to raise, and it's back into normal variation. Like there was one month high for entry. As we discussed, we looked into one of those patients. There was nothing specific. I think James covered that. The MRSA, I just want to highlight there was another MRSA case in entry, and there's another one coming next month, as I've said. And the cannulation issue is the big issue we're dealing with. And then on sickness absence, again, 7.62% at entry. which is the second month for us above the control process limit. And I think that's, again, as we discussed, lots of work going in there, and there is that residual long-term sick stress-related issue at Aintree that we are dealing with and looking at Jen team. And then in terms of the 6 weeks diagnostic turnaround, again, you see the IPR has been increased there in the Aintree as well to 6.1%, which is above the 5% target, and it sits with echocardiography in Aintree, and we have approved some changes to the echocardiograph service as the HMB, which I hope will solve that issue. I'll just move on into finances. So year to date, Aintree is showing 4.7 million deficit, which is 12.9 million behind plan. Income is sustained this month at 1.3 million over plan, taking us a year-to-date position of 8.8 million performance. Expenditure, as just similar to the Royal, is where there's been a deterioration against our plan variance this month, where we've dropped into 2 million behind where we should be. A number of specific issues, similarly as NAC as reported, really escalation areas, waiting list initiatives, that sickness issue as well as driving some of that. And then some very specific issues around our weight loss services, reported previously in terms of where we are with those that have had an impact on pay this month. CIP this month was actually our best performance at 3.5 million in the month, but because of the weighting of CIP, that's still behind the 3.9 million we were supposed to achieve. But that takes us to 23.8 million transacted in the Aintree year to date, up to 6 million behind where we should be. And in recurrent, at the time of HMB, we're at 15.8, but since then we've moved further and we're now at 16.8 million. So
20% in the Royal, Peter.
I know, yeah, we are pushing it as much as we can, Chair. And there's obviously further instructions coming from central sources around recurrent and non-recurrent CIP. I've been through the list in detail many times now, and we're almost into that comply or explain, either make it recurrent or explain why we can't, and we're almost at that point. Not with recurrent CIP. And then finally, I'm just going to end in a positive. James referenced as well at the start. There's been 2 of the wards in the got their platinum LQA, which is really good. It's really good for the teams. The fracture neck unit actually came and did a patient story at our HMB, and it was really great to see just I think the summary would be happy staff, happy patients. So they really do enjoy their work, and we really want to try and bottle that and spread that. There's many examples of it across the trust, of course, but there's something really special in there about enjoying their work, and I think the patients really benefit from it. So I wanted to highlight the positivity there. But I'll pause there and take questions.
Questions. Jackie first.
Yeah, please.
So yeah, congratulations to the team on the LQA to get platinum status is fabulous. And that you've said happy staff, happy patients is a true indication of what's going on there. We did have a little conversation earlier about the category 3 pressure ulcers, and I know our IPR doesn't capture those. And thank you for showing that we've had 8 in the last period. Which is a real worry, and I know that you're investigating that, but I just wondered whether I could just make another plea that we get those numbers in there. I think people have said they will do, and they're not getting in there, but this is where you're getting into that safeguarding arena, and we do need to understand how many we have and what the reasons are. So I know that will come back, so thank you for that. And just really the other thing I wanted to say was around the financial position, and I know it's really hard out there, but seeing those things starting to happen is positive, but it's just, I suppose, where we're going to land and then what the consequences are for next year. And I suppose that's for all the hospitals, because I think that's
Thank you, Jackie. All good points. The category 3, just assurance from me is I do see that in HMB, so I will report stuff up that I need to, but absolutely happy for anyone to see that data. But in terms of those category 3s, that is worrying for me, which is why I've asked for that deep dive. So we're going to look at every single patient to understand if there's anything we could have done to prevent that. I think that's actually been presented, but I haven't seen it yet. But I think it's in Q&S today. It feels like as we speak, and I will see it in a couple of weeks' time at HMB as well. Right. In terms of the finances, I think we'll probably have a bit more of that later on as to what that means, where we land, and we look at this on almost a daily basis, I think. But yeah, we'll probably have some of those conversations later, I suspect.
Mike,
Thanks, Pete. Couple of things. The Platinum Award, worth having a staff story on that, both to celebrate, but also I think for us to understand how we got to the very best practice and how we got there. Just a question on ENT. Once the position's recovered, is it that sustainable?
So really good question, Mike. So again, similar to Max Fax, ENT is going to be in the entry proportion of the group transformation plan next year, because there is transformation needs. We can recover it, hopefully, some risk, as I've said, but the trick is then how do we sustain, as you say, and we need to think completely. The problem with ENT are different problems with Max Fax part of head and neck. ENT is actually really quite productive in terms of, if you look at all their measures, they are really good. The problem is the surrounding areas we service and sometimes the fragility of those services. Not to do with anyone else's, it's a national problem that we have a lot of ENT surgeons, others don't. So a lot of the work comes our way, and there's probably a lot of work that could be handled a different way as well. So we need some transformation. So the sustainability is the group transformation plan, Mike. Absolutely.
Thank you. On that, Pete, then at what point will you be able to come back to the board and say what the timeline is to get back to the 0? I think we've narrowed this down, the 65-week problem. We never planned for it, but we understood it. We narrowed it down to this specialty. But I do think that the increasing focus on long waiters is to be able to get to and consolidate, whether it's at 65 and 52 is really important.
Yeah, I think, the message into the team is that we need to deal with this by the end of March. That is the continuous message that we're putting in. We are meeting almost on a daily basis, and Beth's team are involved with it as well. There is risk of getting to 0 by the end of March, but that is where we want to be, Chair, and really working towards that as the.
Thank you. Beth, then, Chair.
In support of what Pete's saying, so there is the here and now and the BAU, and making sure that we are rigorously managing the numbers, like Pete said. But there's just 2 things I want to reference here. Is there has been a change in national guidance for how we manage our teaching pathways, and I think that will have a positive effect on particularly ENT specialty. That guidance came out in the last couple of weeks, and we're taking that to SMB next week of what that means for us. And the second thing I want to say is, as part of our strategy on the 3 strands that James has talked about, one of them is being faster diagnosis, and actually the pathways which we've identified to focus on some of them relate to ENT, and that's about can we offer and make services more accessible in primary care and community, particularly in ENT. So I'm hoping your question about sustainability, it's not just what we're doing in the hospital, it's also how we can maybe prevent and manage the demand coming into that service for next year.
Yeah, thank you. Yeah, I mean, this is ENT is a bit like dermatology to some degree, gynae, in that there's not enough doctors nationally. If you're the centre that's got the most, if the other services struggle around you, the work comes your way, you then recruit more people, you end up taking them from the places around you, and the work continues to come your way, and we've just got to get to a different way of doing it because there's not the supply of people. I was going to say the point I wanted to make was, and then it's gone. So that wasn't actually the point I wanted to make. So, yeah, don't worry about it. I'm sure I'll remember it in about an hour.
Thank you, Jacob.
Back to the head and neck speciality. And as at NWL, we challenged by getting people seen in a timely way. And one of the answers was there weren't enough doctors for it. Yeah. What are the plans in terms of the transformation?
No, it's a different issue. High level issue. ENT is just not generally enough. They're all almost sort of They're just specialists, but they can cover a lot more sort of diagnoses. The problem with Max Facts is that we're so highly specialist, some single-handed specialisms in that specialism.
And the rare cancers as well.
Correct. And also Max Facts as a specialty, whilst an amazing specialty, requires to do a dual degree both in dentistry and medicine. And currently with the financial pressures in the population generally, most young students now just want a degree. And so there's less people going into Max Facts as a specialty. So it's all like the aging consultant population, highly specialist, with no one coming up the ranks because no one wants to do the two degrees, Jeffrey. So it's a perfect storm, really. So we're looking at trying to do some transformational stuff around having our own almost training pathways, from clinical fellows, etc. Looking at could we do something around forcing people to do the second we really want to do it. So there's a lot of stuff we can do, but it's really specific to Max Facts in terms of that particular specialty.
Rather than CCG, we had a doctor who's duly qualified, but he used all his expertise privately in Leeds.
Yes, there is. So it's about attracting people back into the NHS as well. But yeah, no, you make a good point.
Thanks.
Okay, thank you, Peter.
A lot of detail on the paper, but much of the performance information has been covered in the reports we've already had from James's Chief Exec update on the sites. In terms of the overall status of the improvement plan, the women's plan is currently green, reflecting that many of the programmes are completing within this financial year. The love is amber. Some of the highlights I would draw out within the LUFT plan, the CIP challenge remains, which Rob will be talking to in the final update, so I won't say too much on that. We have 84.4 million transacted at month 10 full year effect against our stretch plan of 114 million. I'd also within the LUFT plan draw out the reduction in some of the risks around the clinical effectiveness programmes following really good work from the IT and digital and the VTE and MSIP and AMS programmes. So we're making progress there. We've reduced 3 of those risks that were 5+ down to 11, and I think we'll continue to see those drop. There's also been improvement recognised within the people and culture programme. James has already drawn out things like the appraisal rates, which are showing continuous improvement, and there's reduction in medical bank and agency spend, which is encouraging. Within the women's improvement plan, I think I'd draw out 2 things. What we know with the System Oversight Group, the importance of the Cancer Files to Diagnosis standard, and that's holding at 70.8%, as James and Jenny have drawn out. I'd also draw out work within the Actively Anti-Racism programme, where colleagues will see in the report that the Trust is featured in number 17 in the top 50 inclusive companies, which if you look at some of the other organisations in the list, that's things like Bupa, Direct Line, Canon, really big organisations that have far greater resources. So I think it shows it's great work for the Trust, but also as we get into the broader LASP agenda, there's some really good practice that we can draw upon across all of the 5 organisations. The 2 other things I would draw out from the report, one is we've got some important System Oversight Group meetings coming up. We have a meeting in March that's looking at the remaining areas, both trusts. It's a joint meeting for LUFT and Liverpool Women's, which will draw out the remaining areas of the exit criteria that we need to evidence in order for both trusts to come out of segment 3. So for LUFT, that is finance and medicines management, and for the women's, it's finance and the cancer recovery. So we'll be bringing papers on both of those. And then in May, there's another important meeting where the ICB have said in the previous meeting in January that the May meeting will be used to take stock of all of the exit criteria, and they'll be giving their reflection on where both trusts are in relation to exit from segment 3. The other interesting thing coming into the May meeting is there is yet another new oversight framework. So colleagues will have been familiar with SOF, with System Oversight Framework. That became NOF, which is the NHS Oversight Framework, and there is a new one as yet to be named. At the moment, we do know there's going to be 5 tiers. So even if both trusts were to maintain at 3, that would be an improvement. But the ICB have also said that. Sorry, I said that a little flippantly, but the ICB have said we will be having a joint look at what the new framework means, where both trusts are going to be matched against that. We'll have to work through some things like your CQC rating is used as one of the many inputs into where you are in the framework, and we're obviously pending within Luft an outcome of our well-led, which you would think could make a bearing on early feature on the segmentation. There's more of that to come, but those 2 meetings are quite important for getting out of segment 3. The final thing that the paper talks about is this thing which we're calling the group transformation plan. So at the moment we have improvement plans in Women's Hospital and within Luft for the last 2 years. As we move towards a group, we are designing the group transformation plan, which is the projects and programs that will deliver on our group strategy, i.e. how we can progress our 3 care models that James talked about in his chief exec update. There's going to be 7 main programs of work within the group transformation plan, 5 that relate to the main hospital sites that we've heard about already this morning, and corporate, and then the 2 other pillars. One will be the last program, which is the Liverpool Adult Acute and Specialist Providers. There's a paper coming up on that later on the agenda. So that's very much what are we doing with the development of the group, and the 5 trusts working as one. And there'll be another program on integrated care partnership, which is how we get into our relationship with Merseycare, Alderhay, and really think about sort of integrated care models. So 5 programs looking at transformation inside the organisation, 2 looking outside. And why is that really important? I think for the last 2 years, we've been really investing in the improvement plan methodology at corporate level. To make that really work now within our wider group, we need to push that capability down into the organisation. So if we're talking about things like dental hospital in the Royal, or orthopaedics and head and neck within Aintree, or the consultant anaesthetic shared service for Liverpool Women's, the sites are benefiting from the transformation methodology and support and very clear plans, and seeing that as a, no, this is over and above business as usual. This is a project or program environment. So I think that's quite an exciting development. We had and we'll do a future board development session on the group transformation plan. Within that, we're also looking at the CIP that we can expect those programs to deliver. As at Tuesday, we had 92 million identified against next year's target. But again, I don't want to steal Rob's up thunder because he's going to have more detail on CIP. So that's where we are, Chair and colleagues. I was going to leave it there, David, and then take questions.
Thank you. Questions, points, please, Victor. Yes, Sarah.
Thank you, Chair. And this may be wildly optimistic, Tim, but indulge me. Just thinking as we move from soft and off and whatever is yet to come, is there a platform within that through the conversations with the ICB then to actually look at those funding mechanisms and the tariffs that are associated with us actually being compliant within those frameworks? Because to Jenny's earlier point, if we look at where we've done so well on the maternity transformation objectives, where we've been brilliant at complying early with the Ockenden outcomes and the things that we had from CQC, all of that came with additional funding that we're now trying to retrospectively do CIP and other things to. So is there a reset opportunity through that for us to say, to get out of Seg 3 and to, you know, be where you're driving us to be? Actually, here is the tariff and the implication that comes with it. So there's a more sensible debate.
So because I was on the meeting that shared the new 5-tiering system. One of the worries I've got is that accountability for that now goes from individual trust directly to NHS England, not the ICB.
Right.
So we're almost in this odd position. Now, we need to see it really to understand it properly, but the determination of our performance and our ratings is going to come via NHS North West. But the commissioning of services is going to come from the ICB. So how do we then?
It's more complex.
So it's going to come back down to for us. And again, when we get to strategy and partnerships, and Tim sort of draws out what he described about the opportunities that we've got through LASP and now this integrated community partnership to deliver multi-year financial benefits. What we're really trying to say is we want to create a strategic commissioning plan for the ICB. This is how we could reorganise things in Liverpool to get the money to the right bits of the system. And, you know, David and I were in a meeting the other day, just looking at in another trust, for example, heading for 14 million surplus at the end of the year, but with greater opportunities around efficiency, productivity, pay, and then almost the opposite of the women's. So I think this will allow us to start to do that ourselves rather than have to ask someone else.
Right, okay.
Thank you.
I just asked this maybe more for Jenny. I was just the transfusion lab and the robot. I noticed that that's been put back ever so slightly. And I was just seeing your level of confidence that the revised plan of implementation, I think it's in September, you feel confident, level of confidence.
Yeah, as confident as I can be at this stage. The issues that we talked about around procurement and the company. And then we did some little suite of tests. And yeah, so it has come back a little bit, but everything else is still on track now. So I'm confident we'll get there.
Can you give us an illustration of the way in which the oversight meetings that you go through with the ICB and others help accelerate the improvement in the trust?
I'll have to think about that one. Well, they don't, frankly.
There's no sort of insight or expertise that comes that you think, oh, yeah, that'll help.
No. In fact, we generally present our position, all the work we've done, the improvement plans and the results. And then the end point is, thank you, that's been really helpful. Last time I asked him to sum up. So, no, this is what will get redefined, though, I think, because the NOF criteria I think was a good mechanism if people could follow it. It was basically, we agree a set of metrics, and if you get there, then we take it off. But unfortunately, what it's led to, in my view, this is a personal opinion, said before anything, this follows. It's basically, I think people in the local system enjoy the opportunity to keep you on the hook too much. So we've actually met criteria and then had, oh great, if it stays there now, well, that wasn't the deal. Actually, if we met the criteria, that's off the list. But you sort of get, oh, we'll review it again in 6 months. And I think there's a bit of, frankly, inexperience and concern about, well, we just need to keep everybody on the hook so we can see what they're doing. That's not how that framework was supposed to work. No. The new one, I worry about. I think they've, I think the principle of it is good, the way that the sections are set out. But to give you an example, there are multiple sections of how your rating will be determined. One of them is latest CQC report. As we know, in some organisations nearby, that could be 2016. We're still waiting for ours. 6 months in, we got a note yesterday saying none of them are ready yet. So, how do you manage that? And I don't think things like the regulatory system, particularly CQC, are able to keep pace with this new structure of regular routine views on organisations yet, and that might be another year. So I sort of have a sense of the way it's going is good. They're trying to be more scientific, but I'm not sure the regulatory environment is going to catch up quickly. So I fear that we'll still be doing this. Well, we're hitting the thing we told you. Oh, great. Well, we'll talk to you again in 6 months and see if it's done. So, but as we said, you and I were talking about yesterday, through all of that process, the thing we agreed that we would hit to be removed from those conditions out of SOP 4 and now SOP 3, I think we're quite relatively unique in the sense that they're all being maintained. They're not slipped back. They're still there. They're still being achieved. So I hope we'll get some sense at the next minute. See. Okay. You too. Rob, Group Finance Monthly Report, month 10.
Okay, thank you, Chair. I'll take the report as read, but recognise it's got some information in there, so we'll provide some bits. Just to note on the numbers at month 10, was at 69.7 million deficit, which was 2.3 million away from plan, slight improvement from huge improvement actually over the past few months, reducing that variance. Liverpool Women's at 10 million, slightly ahead of plan. The official forecasts are to hit plan, 32.8 million for Luft and 11.7 for Liverpool Women's. However, and there'll be a true up in month 11, we've noted a risk adjusted forecast. So for Liverpool Women's is to hit plan. So just focusing on Luft for a second, as at month 10, we were highlighting a risk of about 15.8 million at the end of the year. Now, the key components of that was is non-criteria to reside. So we had about 12 million pounds in our CIP to shut wards this year. That's not happened. And on top of that, there is escalation of the winter that we've all been talking about today. And remembering that usually we're £2 million a year, roughly, and we didn't receive any of that this year, unfortunately. So that's the majority of that variance, but we have been calling out since it occurred really that a shortfall on the pay award of around about £300 and the impact of strike funding of just £2 million. So I note those because they are the key components of the forecast. I think it's fair to say that it's a live situation. We thought a lot of that was kind of dead in the water, but contemporaneously, it looks like there might be some funding being found to meet some of those costs. So that's really good news, and obviously a report back next time on that. As has been noted, actually really good performance on CIP. We shouldn't lose it. £76.5 million year to date is the largest we've ever done even in a full year. But for Luft, 5.3 million at Liverpool Women, which again I think is the largest that's been done. The recurrent effect of that is £68.8 million and Liverpool Women's 2.4. That's a bit of a challenge for us because we're getting asked to deliver the whole thing as recurrent, which whether realistic or not, that's what we're being asked to do. So that remains a challenge for us. In terms of capital, Liverpool Women's going to hit their plan. Liverpool's going to hit its plan, albeit that we've reduced the plan in collaboration with national bodies. So we've slipped 7 million of EPR into next year and 8 million of phase 2 demolition funding into next year. Again, probably a consequence of and a factor of regime. We've done that with the national bodies, so we will hit that plan. And that leaves us to cash, which remains challenged. You can see at the end of the month, Liverpool Women's had £11 million, which is good, around about 22 cash working days. Luft was down to 5.4 million from the 2. Now we've bounced back up because we've been paid at the start of the month, so we will not need any any cash to get through to the end of the financial year, but we will be applying for cash support for Q1. We have to go through quite an arduous process now with daily cash flow submissions, etc. So that's for both Liverpool Women's and Luft. So I'd just like the board's approve permission to apply based on the current scenario. So we'll have to get a signature on yourself, David, and James, but it has to go in, I think, on the 14th of March for Q1. They've changed the process. In terms of the key factors, so just to focus on these, as mentioned earlier, no criteria to reside. It does remain financially, and use of resources a really big issue for us. So oscillating around that 400, it's 24 to 25% of our patient in the hospital at any one time, and again, similar to our bed base. So that's a huge use of resources, 13 to 15 wards, around about £50 million. Now, we are really pushing heavily on the fact that in the tariffs, there has been an increase for non-elective tariffs and for A&E tariffs, and some of that probably is a consequence and feeds into the no criteria to reside issue, so it's all related to flow. But we'll come on to that in the planning guidance. But that's our biggest use of our resources and the biggest reason for the variance, as I've mentioned. The other point to note is the legal claim. Again, we talked about that, and here we're pursuing a legal claim on behalf of the NHS. It's a really strong claim, but the timing of it and the ability to account is likely to fall into next year now. But again, some movement following conversations with NHSE on this and support around that, recognising our position on that. And then, as was noted, and we'll go through it more in the private in the next session, the planning guidance is out. It's a tighter financial environment. The expectation from the system is to improve by around about 25 to 30% on our underlying position, which for our two trusts would be £60.4 million deficit for Luft and 21.4 million for Liverpool. That's the challenge we've been set, and it's going to take a massive effort to get there. I think I'll leave it there to take any questions.
Thank you.
That's perfect. Just on the cash position that you've just outlined there, that you're looking to on a drawdown. Just wanted a bit of assurance around value you're looking at. Explore all the system options into the support there. And is it a timing issue, or is it a bit more fundamental?
Well, I think it's probably more fundamental in the sense of running a deficit. At some point, you're going to run out of cash. So, we are in an underlying position, have been in that position for some time. So, when we use things like non-recurring opportunities off the balance sheet, that's not cash back. So, we've been running down those balances. We have been, and through last, trying to work within the frameworks to move money between ourselves where we can. There's a £15 million stretch in CIP, 11.2 million in Luft's books. 11.2 million of that is in the other four organisations within LAST. I'm happy to say that we've secured that, and that's a good piece of work and built up some trust between us. In terms of the application for Q1, it's likely to be 15 to 20 million for Liverpool Women, 35 to 40 for at Luft. We're still waiting to hear, actually. We did apply for £45 million for this month from NHSE, but the current tendency has been that you don't get what you ask for, basically. So that's why I'm happy to report we can survive till the end of the month in any case without that support.
In terms of timing, is that funding be sort of deducted from future funding, or is it just additional funding that we see?
No, they effectively fund you and then claw it back in.
Right, exactly. Okay, that's helpful. Yeah, great. And can I just ask a question on CIP? Great progress has been made in 24-25. A substantial part of that is recurrent. What is the overview of the CIP programme for 25-26 in terms of building that up? What's that looking like?
Well, I'll cover that in the next part and show but just to confirm, and I think it is worthy of note that actually even identifying the full plans at this stage, so that's 75 million and 10 million at Liverpool Women. So we're over that as identified. doesn't mean it's secured, but that's a much better position than we've been in.
Okay, right, thank you.
But is this the first, sorry, Sarah, just follow up on Tony's point. Is this the first time we've needed cash support in Q1?
In Q1, yes, please.
Is it with women's first time we needed cash support in Q1?
No, not necessarily, but the regime has changed.
I mean, we have to be clear that the earlier in the year we need cash reflects the deterioration in our underlying position. I mean, when you did your update, Jenny, you said there was 6 million, was it, million about this thing? I mean, there was periods where we've sat in the board meetings and feared that the organisation was spending more during the course of the board meeting than we had cash in the bank at the time. The budget just got to the time. And
a £2.5 billion fund coming into this financial year nationally today. There won't be many. We don't need cash support Q1 or
one question. Yes, Sarah, sorry. Sorry.
Appreciating that we've got a lag, so we're talking about kind of month 10 and month 9 actuals, but kind of looking for assurance on how we are exiting the year, really. In terms of month 10 position on CIP at 81 and the plan being 120, so 40 million to deliver in the final 2 months being 50% what we've done in the full prior term. The commentary suggests that we've got line of sight to 95.5 and says we're exploring routes for the remainder. So suggests to me that there's still a 20 million risk there, incremental to the 15.8 that we're calling, with 26 days left to go. What level of assurance can we get that that forecast on CIP?
Well, so I think that bearing in mind that 12 of it that was the no criteria to reside, so that was shutting wards, that won't happen. So if you more or less correlate the CIP position to our shortfall on the end of the year. So at the moment we're thinking 15.8 million, and that might move. The trouble with CIP as well is that you've got to take it out of budgets technically. So it might be that we have some fortuitous underspends that we don't class as CIP within the budgets. So I don't think we will achieve the 14.5 million at look. Said if we get to 95 by the end of the year, I think will be a really good effort.
It's what I'm trying to correlate is if we're saying we're carrying an unmitigated risk of 15.8, where does that sit within this? Because we're forecasting plan at the moment and what's being presented here. So what's the balance between undelivered CIP? That suggests we're making 5 million of savings elsewhere that isn't.
Yeah.
How do we correlate where the risks actually sit in terms of how the numbers are presented?
So the plan is held. We've not been allowed to change the forecast as well. We're not physically allowed. So at month 11, we would do. And at month 11, all things being equal, these numbers would change it to 15.8. The other savings are in the said budget underspends and vacancies held that have not been released with CIP or timing between recruiting somebody and the other person leaving. So there's a whole host of areas that it's not just CIP, albeit the CIP is really important.
It might be useful just to have those additional points of commentary because it's quite difficult to reconcile the forecast and actuals to where we're then saying we think we're going to how to change forecast detail.
Daniel and Jeff.
Just quick, both capital programmes are behind schedule at month 10 to different extents. Are we confident that the capital programmes will deliver in time?
Yes.
For both organisations.
Again, as we announced earlier in the week, I think the wind's moved, hasn't it, in terms of the Secretary of State and the approach to deficits, and the much more passion play now is you have to live within your means. Are we confident I'm sure we are. But actually, no pressure. Hearing what we were hearing before, Sarah's question, but actually, it requires a change of mindset, doesn't it, in terms of how you live within your means. And you can't rely on the bung and the inheritance from your grandma or whatever. We spoke about the litigation. More reminds me of Dickens and Jarndyce and Jarndyce. These things are the can is kicked down the road forever and ever. There's no interest in the respondent settling. So are we confident? I'm sure we are, that we can step up to that greater financial discipline, live within your own means, or decide what you're going to stop doing?
So I think you've possibly been preempting some of the discussions we'll have later on. But slide one, bullet point one is the money, and we keep getting told this in numerous forums, and so the mindset has changed. I think the bit that possibly has not fully been communicated yet is the consequences of that, because you can't necessarily deliver everything you're doing now in the same way you're doing it now within the resource if you're within a deficit, for example. Now, transformation's the way forward, but whether we can get there next year. So,
but the great concern as well, as we found earlier on, is this kind of triumvirate of control and where's power going to sit? NHS England has, they've lost the chief executive and bring the numbers down there. ICBs, delivery of the ICBs and CQC. So I think we're in very uncertain waters. It actually gives us some power, doesn't it, to actually influence all of that. So I see that as an opportunity rather than a threat. But the money will be the biggest challenge.
Yeah, I think to later, but as I said earlier, the triangulation of all the metrics. If you take the women's and love, two slightly different issues. But if you take a love position, for example, the triangulation of the opportunities when benchmarked against everyone else, if we deliver all of them, we get halfway to the number that this organisation needs to get to. So there are still remaining structural issues in our system of not being paid for opening a new hospital and staffing it, for example, and all the resulting costs of that. So we still intend, as we discuss later, and I spoke to the ICB chief executive on Monday night about this, who was sort of giving us good trouble come on to around things like covering legal claims and other stuff. But no funding for a new hospital. So we've been very clear, well, that's fine. We just want to agree the financial target, actually. That's it. So all of the evidence tells us that we're in the right to do that. And we have to take that all the way, really, because as I said earlier, it's been very interesting that right from the national team, we're getting sent stuff that says you could do 80 million, judging by all of our productivity facts. We're saying, well, that's great, because that's the CIP we're planning to do. But the other 80 million, we haven't got it. So where does that sit? And I think, again, if you look at where we would get to next year, the benefits around that, what we've said before, the new hospital funding, you'd be sitting at reference costs of under 100, with having met all the benchmarks in the model hospital, having delivered three concurrent years with 5% plus CIPs. If there's still then a residual gap, then there's a problem somewhere, isn't there? And that's the thing, is that we worry about if we take a tariff change, really pleased to see the tariff recognition around urgent care, gynae, maternity, and probably what's that, about 20 odd million benefit?
What, 35?
35, right. So 35 million of additional recognition of those tariffs. But we know the minute that it comes in, someone's going to go, so we're having this other thing back over here because there's no more money. So I'm sure we'll have a good debate about this later, but it's going to be interesting.
I think one of the things I'm sure you will be doing is keeping the local MPs absolutely tight, that they understand the issues and the challenges. Because
I'm walking one round here tomorrow.
There we are. I knew you would.
I know you were quoting others, Rob, saying this. When more and more people are using the phrase "the money is the money," it irritates the life out of me. People have gone through 3.5 years of professional training, years of building. The best you can come out with is the money is the money. No,
take it on the first slide. It's on his first slide.
Go back to that thing we said before. How we create the conditions for us to improve as much as we can.
Yeah, it's the Trump approach to diplomacy and finance, isn't it?
But that's me. I think I've been clear on that point.
I won't make it. Yeah. It's the red text that I might have to share.
Right, let's move on. Thanks, Rob. perinatal quality surveillance. That's where I'm going to go. Welcome, Diane, who's going to lead us off on all of this.
Absolutely. Hopefully a little bit more straightforward than the last conversation. So of course this paper comes regularly to the board. It's part of our regular quality oversight, both on site and for this board. It also forms part of the maternity incentive scheme at chapter number 9 of year 6, a regular report that I think colleagues are well versed on seeing. This report has been approved through HMP on the 18th of February and sets out the metrics within the scrutiny and oversight. A couple of things to pull out in the report. You will see that there was sadly 3 stillbirths in January. They're all part of PMRT review. They will be reported in future editions. No new PSIIs declared. There's only from claims in there, and just to point out that where you see those actions quite often with our legal claims where there is learning and the claim has been settled due to the very historic nature of them. Quite often the actions that were identified have been superseded by improvements in clinical practice guidance, research, etc. Just to confirm that in terms of training, good compliance, sickness, you'll see a reduction which may have already been covered in Jenny's report in terms of delays in inductions of labour, and good assurance there around the maternity and neonatal strategy. And of course, we get significant oversight and scrutiny from the LMNS for the ICB on delivery of that strategy. And just to confirm that maternity incentive scheme year 6 is being signed off fully by the ICB. We anticipate the report and the outcome of that early April. The incentive scheme for next year, year 7, is likely to pretty much mirror this year's, with a continuing focus on saving babies' lives, which is absolutely welcomed by us at Liverpool Women's. And as soon as that is released, we will provide that update into the board in terms of any anticipated changes or risks. Happy to take any questions.
Thank you, Diane. So we're asked to note the report and receive the assurance that we are on top of this issue. Content with that?
Yes.
Content, Jackie?
Yeah, no, fine.
Thank you very much. Proceed. Love dementia strategy.
Sure. So paper's been distributed just by means of an overview, really. Dementia strategy was produced for 22 to 26 to support the objectives within the dementia and delirium programme, which was part of the Trust's improvement plan at the time. Central goal of the strategy was to improve experience of all patients living with dementia who access our hospitals, and to also engage and involve people's families in terms of, and carers in terms of shaping the care that we provide for them. In December, we took a closure report for the Dementia and Delirium Improvement Programme to Executive Quality and Safety Improvement Group, with a recommendation to formally close the reporting by the Improvement Plan Portfolio Board and hand this over to business as usual governance, which was supported at that forum. I'd just like to make some reference to some of the key achievements from the paper, but ultimately we've continued to improve in delirium screening across Luft, supporting the early identification and treatment of delirium, which is obviously important to aid recovery and prevent deconditioning. We've got a greater compliance in providing, this is me, passport for patients so that teams provide personalised care. Trust-wide dementia training has been delivered across the organisation, and we've enhanced the training for dementia champions, which are a number that we've grown across the organisation in the last 18 months. We've got patients with a confirmed diagnosis of dementia now are routinely referred to the Dementia and Delirium Service, and this is done electronically with an updated referral system, improving accessibility to specialist support. And we've also introduced, I mentioned earlier on, ICON training to clinical staff across all sites to support the ongoing awareness of Mental Capacity Act and managing behaviours of concern. Just to conclude, a capacity and demand review is underway to inform our future standard operating procedure due to the fact that we've seen a significant increase in the last 12 months of referrals to the team. But as noted, and we were successful from a business case that was submitted to the charitable funds for a number of STAR support workers, and the STAR acronym stands for Support, Therapies, Activity and Recovery Workers, to work across each site and support the activities undertaken at each of our Francis centres to optimise the care offer that we provide to patients and families. So that was successful, and work's now underway to introduce these roles across a range of services and to promote non-medication strategies, reduce harm and reduce incidence of regression. And also from the significant amount of work that's been undertaken, we believe that we're in a place now where we can now concentrate on the last year of the strategy to work through we've worked through a number of milestones, but just to focus on the future approach to dementia with a real focus on quality and excellence in terms of clinical outcomes. So that's where the strategy is at this point in time.
Thank you. There's a lot of work being done on this. It's going to be in a much better place than we were a while ago. So we're asked to take assurance on the work that's done. Presented, Colin, thank you. Is there any questions, concerns? Jackie?
Yes, so it's a great report about from where you were to where you are now. I suppose I'm looking for what those key nuggets of things that we're going to have stretch targets for next year, and probably to see a bit more about how the work here can help impact onto ED departments as well, because if we get it going there as well, then we might stop some of those patients coming in and being able to signpost them elsewhere. So just I don't know if we can pick those up.
So we are considering the success measures now in order to be able to measure our performance over the last 12 years of this strategy. We've done an awful lot more in recent months to reaching out to staff surveys of the impact of working in the environment where we may be doing more enhanced observations of care, and also reached out to patients and their relatives to get some real rich feedback coming back that way. But you'll also be able to understand that where we were in terms of just that assessment of delirium on admission, I think we were running at around 20% compliance with that. We're now close to 80% consistently. We're not prepared to rest on our laurels with that. That still means, 2 out of every 10 are not getting that assessment undertaken. So ultimately, we were looking to stretch that to closer to 100% and really drilling in to understand where we can actually get that right in pockets across the organisation. But we will also consider another range of benchmarking and success measures, Jackie.
Tim, then Natalie.
Thanks, Chair. And thanks, Glenn. This is an area that just gives me huge satisfaction. So I think we got it right with the improvement plan, didn't we? Sort of setting a clear strategy to produce the bit we put beneath that, with tailored plans within each of the sites, led by senior nursing. One of the things when I was at NHS that I found really helpful was the peer-to-peer review we had. Was it Cumbria and Northumberland? Yeah. And I think in the paper you list these are sort of now BAU sort of assurance and governance things, but I wonder, could there be a case in a year's time if we think we've got the final year of the strategy to do another peer-to-peer or another follow-up review? Yeah, an extra piece of assurance.
Good suggestion, yeah. Was that from?
Yeah.
Thank you, Natalie.
It was just to say, Jackie, I suppose from a Royal perspective, we've got the challenges of the facilities and the single rooms and we know that that's difficult with dementia and delirium. So we are just about to open 2 dementia rooms. We've converted to facilities to give us some dedicated space on the site, which would be helpful. But the other thing I was just going to say was, I think the frailty work that me and Pete have referenced, so when we come to strategy and partnerships committee, the frailty strategy and the work we want to do and the care the older person clinicians are passionate about is about changing the model of frailty assessment to come away from the EDs. And I think that'll be the prime driver for supporting that. So I think we'll start seeing that come through the improvement plans.
Thank you, Jeffrey.
Really good paper. My question really is about how you're engaging with patients and carers and the expert patient as well. I remember about 10 years ago chairing a conference on dementia, and a guy being a bus driver came along and he lived in dementia and spoke. He was magnificent in terms of what he wanted and what he didn't want in terms of care. So are we using those expert people around to actually inform and shape the care?
Yeah, so we are, and we haven't done as much of it in the last 12 months as we had done previously, but we're re-engaging now. So we had a series of dementia cafes that we're running across each of the sites over a period of time to really reach out and engage, to listen to carer experience and understand what we could do with that to inform things such as our visitors policy, the ability. So whilst the Royal site provides a bit of a challenge sometimes in being able to cohort patients, the big advantage it has is that relatives could potentially stay with their loved ones overnight without it causing too much of an issue. And that's something that we're hearing from relatives quite frequently, that that's something they'd like to take up. So yeah, we are reaching out. We've also done, as I mentioned, a lot of staff engagement in the last 2 or 3 months. We're involved with NHS at the moment around enhanced therapeutic observations of care, a programme of 1 of 10 organisations as part of that collaborative. And as part of that, we've reached out to our healthcare assistants, and ultimately we've had 350 responses to date. And it's quite surprising feedback in relation to a bit of a fear factor at times in relation to providing that one-to-one care, and also more training required in terms of, you know, approaching that. So I think going back to what we said earlier on around Mercy Care and that engagement, we're really looking to try and provide that rich update training and an approach for our staff to do that safely.
Have you considered working in partnership with one of the better care homes who are well rated? You've got a dementia unit, and actually think about some of the healthcare assistants maybe doing a shadow spell there to see how staff on that, how actually well they're well developed in terms of dementia care, how that they could learn from that.
We haven't, but certainly we're open to, you know, all ideas. Definitely, yeah.
I think back to a number of to work at Wiston, and the staff had never been in a nursing home to see what it was like. And I think the challenge of nursing in a nursing home is very different to nursing on the board, but actually you can learn from both ways, I think. And I think that would be the thing. And certainly carers being involved at meal times, helping with feeding is really important. Great.
Thank you. Okay. Before, well done, Colin. Thank you. All good. We've got 2 governance update reports. Firstly, the Liverpool Adult Acute Specialist Providers Joint Committee report. Do you want to introduce Tim?
Thank you, Chair. So we had the thing I mentioned earlier last, which is the Liverpool Adult Acute and Specialist Providers. So this is the 5 trusts one. Very productive committee meeting this month. We've focused on delegated functions. So these are, so at the moment, the joint committee has representatives from all of the 5 trusts. So Chief Exec and Chair of the 5 trusts in Liverpool relating to adult and specialist care. Key things from April, what do we need to be able to deliver our work programme? So the committee considered formal delegations, which you can do under the NHS Act. They haven't agreed those, that's coming back next month, but it'd be things like, if we are to operate finances as one, how would we look to support that? If we want to move to a common digital strategy, how do we do that? If we want to have a sort of overall strategy for group development and thinking as one as the 5 trusts, well, we wouldn't want the individual trust developing separate strategies over the next sort of year to 18 months. So there's a lot of work going on delegations. There's also now a programme of work. There's 8 programmes under the last programme that are committed to developing the group, whether it's our overall strategy, moving to shared services for things like corporate services, digital, finance, estates, people and OD, but also things like how we can develop a common approach to research and innovation, how we can be more commercial across the 5 trusts. So those programmes are live, but all of the, and they've got a senior responsible owner who is an executive from one of the 5 trusts leading those programmes of work. One of the things the Joint Committee considered this month is the resource plan required. These are, you know, things like developing a shared digital service or developing a strategic outline case for all of the 5 trusts, and they're quite large endeavours. So we are putting together a resource plan, and the intention and the Joint Committee have signed off a resource plan that would be then put to the ICB with a funding request and support request for next year. Now that needs to be taken in the context that Rob's talked us through, a very challenging financial envelope, but nevertheless the resource request for something that's going to be made. The other, I guess, significant point of discussion was around how we've sort of complete circle of the joint committee wants to act as one from a financial perspective, but finances can't be delegated under the NHS Act into a joint committee. That's what's known as a retained function. So we need to sort of complete the magic trick of having retained financial authority, but actually trying to take a combined look at things like CIP, prioritisation of capital, how we manage to a single financial control, total and share risk. So there's been a commitment to establish a last finance subcommittee beneath the joint committee with NED and exec representation from across the 5 trusts. That's going to be in place in future weeks to come. But I think they were the main elements of the joint committee.
Thank you. Just to add to that, I think, like all good committees, boards, we get to the right place through different people expressing the different perspectives and views about where we're at, where we need to get to. I felt that this was the most productive meeting we'd had yet. Last one. One of the things that really helped that is that there's been an ongoing discussion about the whole HR side of this and how the transition into working in a different way, what that meant for individual people and so on, and a concern that no trust got left behind in any of that, and that everyone had there were a suite of papers which James presented into the meeting, which I think allayed a lot of concerns and answered lots of questions about that, and I thought that was very significant in helping us now move to the next stage. But in the context of the planning for next year, the way we do business together, the way that Tim highlights, it's a critical point now. We've spent the majority of the time so far talking about how we're going to do things in the future. Now we're at the point where we have to do it together in a different way than we recognise the point that we're at. So I thought it was very positive.
No, I think once you get to the point of trying to really figure out delegations, I think that's when there's, as you say, the crunch point is there. It's easy to talk about collaborating on something until it gets complicated and people can then step away. The delegations are critical, really. So that allows us to make those decisions when we need to make them rather than constantly going back to Bible at the discussion. Jeffrey.
Thanks, Ben. Great report. It's easy to see HROD and culture development as a cost rather than investment. I know Heather will share this view, but actually I think all the research shows that trusts that have really good HROD and culture programs have better outcomes for patients, which is back to Jim's point before, but happy patients make happy staff make for happy patients. So it's easy to see an easy, cheap cost-cutting service, but actually the investment in OD and the culture and that brand for the whole organisation is key to success in the future.
Thank you. Audit Committee Assurance Report. I thought David would have been here by now.
Mike's going to pick this up.
Yeah. Mike, could you pick that back up?
Thank you. This was an extra meeting to cover off internal audits. So it's internal audit focused only, and in the spirit of good meetings, I think this was it's the best one we've had as an audit committee. I think the things that we want to see from internal audit around good ownership and good process, they are now there. There was a really good example of execs commissioning a piece of internal audit because they were concerned, and that organisational reflection and honesty that came through really strongly. So I think we've moved away now from concerns about process into proper interrogation of content and assurance. So I think it's a really step forward.
We're happy to note receive the paper. Thank you very much. We've concluded all the formal business of the meeting. Draw out the risk issues that I don't think there's anything new that's emerged in the discussion, Daniel, that affects the blackboard and so on, but we'll pick that up. I think we've dealt, I'm looking to you, Daniel, again, I think we've dealt with the questions that we were notified of and they come through, particularly through Jenny.
I'm sure that they're published in the minutes within the website as well.
Okay, thank you. So for this part, yes,
Can I share one piece of news for the board?
Yes,
I
of
got
course.
excited on. Jennifer Deeney is at the Northern Power Women Awards this evening. She's up for an award for her work for neonatal services. I think she's the only NHS nominee, so nice things I'm very proud of. So hopefully some good news for her this evening.
Thank you. Okay, we reconvene in private in 20-25 minutes. Very much. Meeting closed.